the risk factors, classification, diagnosis, and the management of acute aortic dissection. Recently, none of the questions has been asked on acute aortic dissection. I think this was in 2017 or 18 in one of the FNB exams. It has been asked once, the classification and management of aortic dissection for 5 marks. Now, so what is aortic dissection? It is nothing but a tear in the intimal lining of the aorta, which extends into the media of the wall. So as you can see here, this is a healthy vessel where this is the intimal layer, medial layer, and adventitia layer. So what happens in acute aortic dissection? Usually there will be a tear here in the intima and the blood flows from the lumen through the intima into the medial layer, forming a false passage or a false lumen. Later, if the pressure increases, it may lead to the rupture of the vessel. So what happens? The blood flow through this tear leads to the formation of a false passage, which is bordered by the inner and outer layers of the media. So as I told, these are the stages of aortic dissection. Stage 1 is nothing but the rupture of intima. Stage 2 will be the dissection of media. And stage 3 is the rupture of the vessel. Now coming to the causes or the risk factors for aortic dissection. So the most common cause is the connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome. History of cocaine use, hypertension, iatrogenic secondary to cardiac catheterization or any cardiac surgery or due to Iabp. Pregnancy is also one of the cause for aortic dissection. Any structural defects in the heart like bicuspid aortic valve, coarctation of aorta or annular aortic ectasia. Secondary to any complications of syphilis, trauma, vasculitis like giant cell arteritis or Takayasu arteritis, or any other heritable conditions like adult polycystic kidney disease, osteogenesis imperfecta, homocystinuria, or Turner syndrome. So coming to the classification of acute aortic dissection. So it has been broadly classified. One is by their location or the site, and the second one is by the chronicity. So by the location, two important classification systems are there. One is the DeBakey's classification. The other one is the Stanford classification. So DeBakey's classification has 3 types, type 1, type 2, type 3, and Stanford has 2 types, the type A and type B. So DBK type 1 is basically involving the ascending aorta, the arch of aorta, and also it can involve the descending aorta. Whereas in type 2, it involves only the ascending aorta, but not the arch nor the descending aorta. In type 3, it basically involves the descending aorta and arises after the left subclavian artery. Okay. So the type 1 and type 2 of DeBakey's is known as type A of Stanford. That is basically it involves the ascending aorta. Ascending aorta is basically it arises from the ascending aorta, whereas in type B, there is no involvement of any ascending aorta or the arch of aorta. It is purely the descending aorta. So this is what I told, DBK type 1, type 2, type 3. And in type 3, you have 2 things. As I told, it originates distal to the left subclavian artery. And type 3A is, it is only limited to descending thoracic aorta, whereas type B, it also extends below the diaphragm involving the abdominal aorta. Stanford, as we have already discussed. Now by chronicity, it is classified into acute, subacute and chronic. Acute is the occurrence of this dissection within 14 days of onset of pain. So symptom to the dissection is 14 days. Subacute is between 15 to 90 days. And if it is more than 90 days, it is chronic. Now coming to the clinical features. So clinical features basically depend on the site of the dissection, whether it is Stanford type A or type B. So type A means it basically involves the ascending and the arch of aorta. So 2 important organs are involved. One is the brain and the other one is the heart. So usually these patients will complain of severe chest pain, syncope, aortic insufficiency, myocardial ischemia, neurological signs, and in some cases even the pulse differential if it is involving the descending aorta also. So in Stanford B, it is basically the descending aorta. So the most important organ symptoms are organ involved are one is kidney and the other one is the limbs. So usually patient complains of severe chest, back or any migrating pain. There is distal pulse differential. There could be limb pain or claudication and renal insufficiency. And in certain cases, there is high blood pressure. So rapid diagnosis is vital because treatment is time critical. So greater than 20% of these patients usually die before reaching hospital and more than 50% of these patients die before reaching a specialist center. And mortality increases by 1 to 2% after every hour of symptom onset. So you should be very fast in diagnosing it and treating it. So how do you diagnose or what are the investigations which are usually done in acute aortic dissection? The most common one which we do is a computed tomography. So it is the first line imaging technique for the diagnosis of acute dissection. So what do we see here? We usually see what is the type of the aortic dissection, where is the position, the size of the dissection, and also to rule out any other differential diagnosis. So the preferred protocol is a non-enhanced CT, which is followed by a contrast-enhanced CT angiography. Okay. So basically it has to, it has to cover the entire aorta, the thoracic aorta as well as the abdominal aorta. So you have to do both the CT chest as well as the abdomen with the angiography of both. So what do you see is a presence of a visible dissection flap, and that is known as tennis ball sign. So if you see, it's a type A dissection involving the ascending aorta. So this is the tennis ball sign where you have a true lumen and the false lumen. The same thing in type B, the descending aorta having a true lumen and the false lumen, which is separated by the dissection flap. Now the second important thing which we usually do bedside is the echocardiography, point of care echocardiography, right? So this is just the advantages and disadvantages of TTE and transesophageal echocardiography in acute aortic dissection. So TTE, basically it is less invasive and it's more readily available, whereas esophageal echo is more useful in while you are performing the operation, basically in the operating room, or if the patient is in the ICU, intubated, ventilated, and you can't shift for a CT, then you can do a transesophageal echo in the ICU also. So you usually see the aortic valve, aortic root, ascending aorta, and the pericardium. And what is the view that we usually use in the transthoracic echo is the suprasternal echocardiographic window, where you can actually see the arch of the aorta. Now, if you see, this is a parasternal long axis view, where you're seeing the LV, LA, and here you can see the dilated aortic root with some dissection flap. And this image is basically showing the aortic insufficiency. So what are the general echocardiographic findings in acute aortic dissection? One is, as I told, there will be a dissection flap, which can be seen as a mobile linear echogenic line separating the true and the false lumen. Also, you can see aortic regurgitation if there is an aortic valve disruption. You can see pericardial effusion, any aortic root dilatation, and suppose if it involves any of the coronaries, you may also see the regional wall motion abnormality. So as I told, you do a transthoracic echo. Simultaneously, you also need to do the abdominal aorta scanning which you can see in the USG abdomen. So what are the typical appearances that you can see is the presence of a flap or a thin membrane fluttering within the vessel. And if you put a color Doppler, you will be knowing the presence of flow through the false lumen. So if you use both this abdominal aorta scanning along with the TE, then the sensitivity is around 67 to 80% and the specificity goes up to nearly 99 to 100% for diagnosing an acute dissection. So the other modality which we can do is the MRI, who has contraindications to any CT. It has a specificity of around 98%, but the limitations are it is not available in certain institutions. Important one is there is a prolonged scan time, and also monitoring is very difficult in such cases. And as we know, if any metal implants are there, such as pacemakers, it is not possible for us to do the MRI scanning. So can you detect in the ECG? Yeah. in around more than 70% of patients, especially when it is a type A acute dissection and basically it involves the coronaries, you can see all the STT elevations, depressions, and some non-specific T-wave changes also. And the presence of these ECG changes are usually associated with increased incidence of shock as well as cardiac tamponade. And when you come to the chest X-ray, you can see a widened mediastinum, especially if it is a type A aortic dissection. Uh, in around 20% of patients, you will not be able to see this widened mediastinum. And the other one is the cardiomegaly, which you usually see if there is a pericardial effusion or there is an aortic valve incompetency. And some biochemical markers, like they have done a meta-analysis on D-dimer values in aortic dissection, and they have found that if the values are more than or equal to 500 nanogram per ml, it is associated with around 97% of sensitivity, but the specificity is very low. It is around only 56%. Now coming to the important part, the management. So what is the initial management? Basically, you should more stress on the resuscitation as well as the stabilization of the patient, whilst deciding and preparing for definitive intervention, whether you want to do medical management or whether you want to do a surgery. So what is the main goal of the management of these patients is you have to reduce the shear forces being placed on the aorta, whilst ensuring sufficient organ perfusion. This means that you have to maintain the proper heart rate, proper blood pressure, so that there is no much pressure on the aorta which might lead to any rupture, or you should not keep the BP so low that there is no it might hinder the organ perfusion. Okay, so this is a best way of writing your management in your exams. So if there is a suspected aortic dissection, okay, what are my targets that I have to maintain? So first target is you have to maintain your saturations of more than 95%. Your hemoglobin should be more than 12 gram per dl. Your systolic blood pressure should be within 100 to 120 mmHg, and your heart rate should be between 60 to 80. So these are the targets. Okay. Then you start your initial stabilization by assessment, by securing the wide bore IV access, give fluids. You have to start an invasive BP monitoring, and you have to the other important thing is you have to ensure adequate analgesia, because these patient complaints of severe chest pain or backache. Okay. So after your initial stabilization, okay, then you decide whether you can shift this patient to either CT scan. If not, at least do a bedside TE. So at the same time, you have to also discuss with your surgical team whether at what point of time you want to either operate this patient or not operate this patients. So after doing the CT, you have diagnosed whether it is a type A dissection or a type B dissection. If it is a type A dissection, there is only one important management that you have to do is a urgent surgical intervention. Okay, you have to do an open surgical repair. But if it is a type B dissection, you should then divide whether these patients has a complicated type B or an uncomplicated type B. Now, what is this complicated type B dissection? If there is a persistent refractory pain, if there is malperfusion, means if there is limb claudication, or if there is renals are involved, renal system is involved, or if there is a rupture or leak, or if you say there is a rapid expansion of the false lumen, then it is known as complicated type B dissection. And in such cases, you have to do a surgical intervention, but here you do is a endovascular repair. Okay. And if it is an uncomplicated type B, then only medical management is sufficient. Okay. So type A dissection, it is an open surgical repair. Type B complicated, it is endovascular repair. And type B uncomplicated, it is medical management. So coming to the blood pressure management, as I told, you have to mention this word, tight blood pressure control. This is very important. So tight blood pressure control, and there should be reduction of the rate of pressure rise during systole. Okay, these both are very important to reduce the chances of dissection propagating further. So what is the shear force? As I told, what is the shear force within the aorta? It is basically defined by the any change in pressure over time, that is dP by dt. And the rate at which an intimal tear propagates is actually directly proportional to dP by dt. That is nothing but we have to basically manage your blood pressure, especially the systolic blood pressure. So in absence of any aortic regurgitation, the first line of antihypertensive which we use in aortic regurgitation, sorry, in aortic dissection is the beta blocker. Okay. So beta blockers helps both in maintaining the heart rate as well as the BP. So what are the targets? So your heart rate should be, as I told, 60 to 80 per minute, and your systolic blood pressure should be between 100 to 120 mmHg. This is the target before your operation or in any type B uncomplicated cases. Okay, so which is the most common beta blocker which can be used is esmolol, labetalol or metoprolol. Better would be esmolol because it is short acting. So the loading dose is around 200 microgram per kg per minute, which is followed by an infusion of around 50 microgram per kg per minute for 4 minutes. Further loading doses and maintaining doses should be used as and when required. Then the other two are the labetalol and metoprolol. Next, if the patients are not tolerant or if there is any contraindication to beta blockers, then the next best antihypertensives would be the non-dihydropyridine calcium channel blockers. That is nothing but the diltiazem or the verapamil. Okay. And with this also, if the BP is not controlled, the last measure would be the vasodilators, but you should be very careful while using this vasodilators because they may produce a reflex tachycardia, which may exacerbate the myocardial ischemia or the aortic dissection, further proceeding into rupture. Now, this is a very good algorithm for the BP control. So, first two important things has to be managed. One is, as I told, the rate, the heart rate and the pressure control, which is best achieved by a beta blocker. That is either by intravenous esmolol or labetalol. And then titrate the heart rate to less than 60. At the same time, you should also take care of your pain. Okay, so pain control should be adequate. Best to use is the intravenous opiates. So with these two things also, if the BP is still more than 120 mmHg, the systolic BP, then you think of adding a vasodilator, or in some cases, the ACE inhibitors also can be used, and you have to titrate the BP to less than 120 mmHg. So what is your goal is the lowest possible BP which can maintain the adequate organ perfusion has to be kept. Now coming to the surgical treatment of acute aortic dissection, as I told, open surgical repair is a must for type A aortic dissection. Okay, it should be undertaken as soon as possible after diagnosis. So basic principle, I'm not going into detail, only some important points I've highlighted in the surgery part. So basically you reset the primary tear, you establish the blood flow in the true lumen, and then you replace the dissected intrapericardial aorta. Now, in surgical principle, two things are important. One is you initiate a CPB in these patients, and second is cerebral protection is a must. You should take care of the brain. Otherwise, these patients might have a very bad stroke post-operatively. Okay. So basically the preferred cannulation is directly you can either cannulate into the ascending aorta, or indirectly you can cannulate either in one of the axillary artery or the femoral artery. And as I told, cerebral protection. So you have to perform the anastomosis without using any cross clamp. And this cerebral protection can be achieved by two methods. One is by deep hypothermic circulatory arrest, or the other one is the antegrade cerebral perfusion. Okay. The third important point is you have to maintain a stable intrathecal pressure. Because in these patients, if there is a fluctuations during the surgery, okay, there is a risk of paraplegia post-operatively. So in order to maintain a stable intrathecal pressure, you insert a spinal drain before the onset of surgery. Okay, so these three important things are important. One is the aortic cross clamping should not be used. The second one is the cerebral protection. Third one is in order to prevent the paraplegia, you have to insert a spinal drain preoperatively or just before the surgery. Now coming to the early post-operative complications. So what can you expect is, one is there could be multi-organ dysfunction because it is more because you are under surgeries, emergency, and basically it involves multi-organs. So you can expect post-operative multi-organ dysfunction. The other one is the post-operative dialysis. So as I told, stroke is most common in these patients. So around the incidence is around 9 to 10%. And the other thing is due to hypothermia and prolonged CPP, there could be any bleeding diastasis or coagulopathy abnormalities. And the last one is the spinal cord ischemia. Now, post-operative spinal cord perfusion optimization. So as I told, spinal ischemia is a significant potential complication following aortic dissection repair. So you have to manage the post-operative course, which basically include monitoring using neurophysiological and intracranial or the ICP monitoring. And you have to drain the CSF for up to 72 hours. If any neurological deficit is identified, measures should be instigated to optimize the spinal cord perfusion and thus negate its progression. So how can this be done is something known as COPS protocol. So what is COPS protocol? So this is basically in the post-operative. So C stands for CSF drainage, O stand for oxygen delivery, PS stand for patient status. So see, because you have put a CSF spinal drain, you have to see if there is any malfunction which is going on. Next, you have to see that the patient lies flat post-operatively. You have to maintain the drain pressure of less than 5 mm Hg, and the drain has to be kept for nearly 7 days post-operatively. Next, whether you see the oxygen delivery is normal or what. Okay, so you have to maintain the oxygen, monitor the oxygen saturations, maintain hemoglobin of more than 10 mg per dl, and you have to maintain the cardiac index of more than 2.5 liters. Then coming to the patient status, you have to maintain the systolic BP more than 120 after the surgery. Okay, so before the surgery, it is 100 to 120. After the surgery, it has to be maintained more than 130 to maintain the perfusions. Okay, and the CPP uh, uh, should be maintained above 120. And the cognitive status, that is, how is the cognitive status of the patient has to be seen. And you see whether the CSF has any blood in it. So this is about the surgery in type A. Coming to type B, aortic dissection. So as I told, if it is uncomplicated, the best line of management would be a medical line of management. So approximately 90% of these patients can be managed medically, and intervention, as I told, is required only if it is complicated. So as I told, complicated, 4 important things. If there is a persistent refractory pain, if there is a rupture or leak, if there is a rapid aortic expansion, or if there is a malperfusion. And the best surgical method is, as I told, endovascular, that is the TVAR, thoracic endovascular aortic repair. Okay, so this is basically, as I told, complicated dissection. All of this, you have to see whether there is a suitable proximal and distal seal zone is present or not. This can be assessed by either CT or a TOE. And if this is present, then you can do the endovascular repair. If still there is a persistent renal or visceral malperfusion, then you have to do adjunctive renal or visceral stenting has to be done. Suppose if there is a no suitable proximal and distal seal zone is not present, then you have to do open surgical repair. So this is how you perform the TVAR. Basically, a guide wire is inserted through the femoral and the graft is placed here. Your aneurysmal site is here. So basically, same as placing a stent in the heart also. So basically, this graft is placed here and the aortic repair is done. So coming to the post-operative care. So pain management is very important in these patients. So basically, they require a multimodal analgesia. And physiotherapy basically to prevent the post-operative pulmonary complications, and rehabilitation in these patients are very important, which can be done by early mobilization, daily orientation, engagement with family members, spontaneous awakening and breathing trials, sleep promotion, daily assessment for delirium, and the CAM ICU score. So as I to conclude this, so aortic dissection represents a condition with significant morbidity and mortality. So identify it faster, and if required, please take to the surgery immediately. And post-op management of these patients are also very important. So successful treatment relies on rapid diagnosis, strict blood pressure control, minimal delays to definitive treatment, and multidisciplinary team input. These are my references. Thank you.
Thank you, ma'am.
Darshan, will you start with your topic?
Yes, ma'am. Starting. Am I audible?
Yeah, you're audible. Yeah. Mhm.
Is my screen visible?
Yeah, visible, Darshan.
Okay. So, good evening, everyone. So, the next topic for the day is cardiogenic shock. So, the outline of the talk is basically under the following headings: definition, classification, pathophysiology, approach, management, and recent advances. Mostly in cardiology, questions regarding shock have been very little or more or less very precise. So the questions regarding cardiogenic shock have not been asked in specific, but there have been questions asking to describe what is shock and describe any type of a shock. So if you are interested in presenting this, it's okay, but most of us usually tend to talk about septic shock or another type of shock. So that is left to you. But this is what we thought it will be helpful if they ask cardiogenic shock per se. So coming to the epidemiology, mostly it is related to acute coronary syndrome, that is 60 to 80%, and mostly in
Sorry to
ACS it
interrupt.
is related to STEMI.
Darshan sir, sorry to interrupt. Could
Sure.
you please little bit minimize or less manage your screen because it
Mhm.
uh, you can F5 or presenting mode.
Yeah. Is this okay?
Niharika madam, could you please check like if it is okay for me or
I
because
think it's
half up screen we can able to see and half up screen
Yeah,
we are not
candidates
able to
are
see.
showing thumbs up, I think so, Navneet. I think so.
no, I think we are able to see it properly. Complete slide, I'm able to see.
Okay, okay. Yeah, I've got a couple of thumbs ups. I guess that should be all right.
Okay, great sir.
Okay,
Thank you,
okay,
sir.
thank you. So going ahead, so cardiogenic shock, like I was telling you, the epidemiology usually is related to MI, and very rarely it can also be related to chronic cardiac diseases as such, but the mortality is quite high. That is the importance of this class. So coming to the definition of cardiogenic shock, it is a life-threatening syndrome primarily due to cardiac dysfunction. And the clinical definition of cardiogenic shock varies, which usually includes two signs, that is hypotension along with hypoperfusion. So there have been various definitions which have come forth in the past decade or so, and before that as well. But no one size fits all definition was used until recently. So the myocardial dysfunction, majorly which causes cardiogenic shock, may vary due to ischemia, or sometimes it may be associated with a severe state like cardiac arrest. So what is the major problem with definition is the ESC guidelines were given way back, around 10 to 12 years ago, and they were kind of subjective and they did not have objective parameters, if you can see on the left-hand side of the slide. So except systolic blood pressure, rest of the parameters were clinical and laboratory parameters with some amount of hemodynamic criteria involved. Slowly, there were many trials for cardiology where they have used different definitions of cardiogenic shock per trial basis, but per se there was no definition until recently when the Society of Cardiovascular Angiography and Intervention came in with a comprehensive definition parameters. It involved both hemodynamic parameters, clinical parameters, and as well as hemodynamic parameters. So, what is the established criteria for cardiogenic shock? It's defined as a systolic blood pressure of less than 90 millimeters of mercury present for more than 30 minutes, or requirement of vasopressors to achieve a systolic blood pressure of more than 90 millimeters of mercury. The pulmonary congestion or elevated left ventricular filling pressures, which is determined by a PCWP of more than 15 to 18 millimeters of mercury, that is the pulmonary capillary wedge pressure, or if the patient shows one of the signs of impaired organ perfusion. So one sign of organ perfusion impairment is necessary. That might be altered mental status, cold clammy skin or extremities, oliguria where the urine output is defined as less than 30 ml per hour, or an elevated serum lactate of more than 2 millimoles per liter. Along with this, if the patient has a cardiac index of less than 1.8 liters per minute per meter square, with or without support, if it is with the support, then it can be around 2 to 2.2 liters per minute per meter square. But the requirement of cardiac index for the diagnosis of cardiogenic shock is optional. So if you have a systolic blood pressure less than 90, persistent for more than 30 minutes, with signs of pulmonary congestion and organ impairment, that itself is classified as cardiogenic shock. So coming to the classification, it is, as I told you, it is based on this SCI criteria, hemodynamic criteria, or a phenotypic criteria. So what is SCI? That is Society of Cardiovascular Angiography and Intervention. And how does that define cardiogenic shock? It starts by categorizing people from stages A, B, C, D, and E. These stages are basically based on few parameters. It can be clinical parameters, it can be laboratory parameters, it can be hemodynamic parameters. So if a patient has a cardiac event or has a cardiac disease, but he's hemodynamically stable without experiencing any signs or symptoms of shock, then he comes at patient who might be at risk. If the patient has no signs of hemodynamic instability, but has hypotension only, then the patients get classified as B or beginning. Here, what is to be noted is there will be hypotension, but there is no hypoperfusion. Classic is a place where the patients have significant hypoperfusion. And this stage, the patient usually requires some pharmacological or mechanical support that needs to be given to the patient to maintain hemodynamics. Deteriorating or D and extremis E are usually end stages of cardiogenic shock, wherein the patient's overall outcome would be very less and the mortality is usually high. So whenever the patient ends up in a stage B and C, interventions at this stage would give better outcomes. So firstly, patient has a cardiac problem, A, but no shock or no hypoperfusion. B, patient has shock, that is hypotension is present, but no hypoperfusion. In C, hypoperfusion and hypotension is not getting alleviated by regular treatment, so needs pharmacological or mechanical circulatory devices. D and E is refractory to treatment with routine care. Probably they need a further management, which can include an ECMO or probably the worst case scenario, heart transplant. So coming to phenotypic classification, cardiogenic shock, I've already told you, can be divided as shock causing hypoperfusion or shock causing congestion. Whenever patients having a cardiogenic shock causes hypoperfusion, it can be seen like acute kidney injury, that is our cardiorenal syndromes, or it can cause encephalopathy. But if it is associated with predominantly congestive type of a picture, then it is usually associated with hepatopathy and pulmonary edema. So what is the hemodynamic classification? Till now, whatever I said is more or less theoretical and really difficult to say. And you cannot put one finger and tell that this patient is only purely AKI or purely having hepatopathy, or patient has encephalopathy. So Forrester's classification is something that we have routinely been using. So what it usually has is two parameters. That is, it checks how the perfusion status is, and it usually checks how the congestion status is. The perfusion status is indicated by cardiac index, which is the y-axis, and the x-axis is the pulmonary capillary wedge pressure. So based on the cardiac index and the pulmonary capillary wedge pressure, it is usually divided into four classes. That is Forrester class 1, class 2, class 3, and class 4. Forrester class 1 is usually the safest person. So usually if you ask us to correlate this to a SCAI criteria, these patients fall in the class A of SCAI. So these patients have a good cardiac index, usually more than 2.2, and they have dry lungs, that is no signs of congestion. So for that reason, the mortality associated with Forrester class 1 is less than 3%. Whereas if you step towards a patient with Forrester class 2, even though the patient has a good perfusion, that is the cardiac index of more than 2.2 liters, they usually have signs of congestion. So they can come under a patient with Sky B or Sky C. Okay. So these patients might need optimization, and that is one of the reasons they have a mortality of up to 9%. The next class of patients are the most morbid patients. They are the Forrester class 3 and Forrester class 4. In Forrester class 3, there is decreased cardiac index as well as increased they have a decreased cardiac index, because of which the patients usually are cold, but luckily they don't have any signs of congestion. So since they have a decreased perfusion, they are mostly prone to have oliguria, renal failure, hyponatremia, and cool extremities. And that is one of the reasons the mortality ranges up to 23%. But if you see patients with the Forrester class 4, which is associated with cold and wet, they have an increased capillary wedge pressure leading to congestion, and at the same time they have a decreased cardiac index. So these patients in the Forrester class 4 have the highest mortality of up to 51%. So this is what we need to understand. How are they placed based on perfusion and congestion? Coming to the etiology. So whenever a patient comes with cardiogenic shock, firstly, we label these patients based on all the above criteria that I mentioned. But the main clinical thing that we need to rule out is the cardiogenic shock caused by a myocardial infarction, or it is not associated with myocardial infarction. That is the basic understanding for any patient who presents to you in a ICU. So when it is related to MI, then the question that needs to be asked is it causing pump failure? Is it causing a mechanical complication, or it is associated with any conduction system abnormality? So what do I mean by pump failure? Usually a large infarction involving more or less 40% of the left ventricle, with the patient having a prior infarction or a pre-existing LV dysfunction, or an infarct expansion during the stay of the ICU, or a patient who has a reinfarction. So these things can lead to a pump failure, wherein the patient ends up having a decreased cardiac output, which is attributed to by a probable reduction in the cardiac index. So the other mechanical complications that are associated with cardiogenic shock are acute MR secondary to rupture of chordae or papillary muscle, VSD secondary to septal rupture or tear, LV pseudoaneurysm, and left ventricular free wall rupture. So what are the non-MI related causes of cardiogenic shock? There are many. It might be end-stage cardiomyopathy, myocarditis, septic cardiomyopathy, LVOT obstructions as seen in HOCM or AS, or toxins or drugs, dysarrhythmias, prolonged cardiopulmonary bypass. So these are the non-MI related causes of cardiogenic shock. So the most important thing that we need to know at this stage is we have an MI related or a non-MI related shock. So if it is MI related, what are we supposed to do? Look at the heart. Look at the heart for probable mechanical complications, rule out all of this. If it is not, then we need to further work up this patient. So what usually happens? What is the pathophysiology in cardiogenic shock? You have an acute trigger, which leads to myocardial dysfunction, which leads to decreased cardiac output and decreased stroke volume. And because of the decreased cardiac output and decreased stroke volume, the patient will either have hypotension or decreased systemic perfusion. Because of these two, a neurohumoral compensation sets in. The neurohumoral compensation that is set in is increase in heart rate, vascular resistance, and fluid and sodium retention, because of which there sets in a maladaptive consequence that can be increased myocardial oxygen consumption, that may be because of increased heart rate, vascular resistance, or the fluid overload causing myocardial stretch. It can cause decreased coronary perfusion and also cause increase in filling pressure. If this is not arrested at this stage, it leads to progression of the cardiac dysfunction, and progression of cardiac dysfunction leads to congestion, myocardial ischemia, and further worsens the hypoperfusion. And because of hypoperfusion setting in, the patient can lead up into a progressive metabolic dysfunction, inflammation, and have a multi-system involvement leading to end organ dysfunction. And when the patient ends up in an end organ dysfunction, this is usually seen as severe acidemia, vasoplegia, or a patient might end up with refractory shock and can lead to death. So how do we usually go about when a patient presents to us with a cardiac event and has developed cardiogenic shock? The first thing is we need to evaluate this patient in the golden hour. So golden hour still holds good even in this case. Okay. So firstly, we need to detect which classification of sky does the patient belong to, and see how bad the patient is. If he's in sky C, D, and E, we need to act quickly and optimize him at the earliest. So once we have stratified the patient on arrival, then we need to see what is the phenotyping. The major thing in phenotyping is we need to see if it is an MI related cardiogenic shock or a non-MI related cardiogenic shock. When I tell non-MI related, probably a myocardial dysfunction, which leads to acute decompensated heart failure, and acute decompensated heart failure presenting as cardiogenic shock. So we need to rule out these two things, because if it's an acute MI causing cardiogenic shock, we need to act quickly, and probably PCI would be required in this case. So once we have stratified, phenotype this patient, we need to optimize this patient. The optimization is usually achieving MAP targets, oxygen delivery, and securing all our ABCs in the same time, also doing the basic lab works. After this, we have to do a de-escalation or exit therapy. This is usually done based on the primary cause. If it is MI related, first do a PCI and then come back and de-escalate all the medications. If it is non-MI related, if it's a cardiogenic shock due to heart failure, then we need to look at our options. So symptomatology when a patient presents to you with cardiogenic shock is usually related to whether it is right-sided failure or a left-sided failure. And usually there are shared findings also, which is seen. And these symptomatology is something that we have been reading from a long time. Right-sided heart failure usually is secondary to congestion, probably due to congestive hepatomegaly, raised JVP, regurgitated murmur, or it can also lead to dependent edema. In the left-sided failure, it is usually related to pump. So pump failure usually causes decreased output, and sometimes even the pump failure can cause a back pressure, causing severe respiratory distress due to pulmonary edema, respiratory wheeze, and left-sided heart murmurs. And if there is a biventricular failure, or if both are involved together, it can lead to cool periphery, cyanosis, orthopnea, and delayed capillary refill, which is an indicator of poor cardiac output. So what is early detection got to do with all of this? So we have already seen the patient. We need to assign the patient for a sky grade and rule out whether it is cardiogenic or non-cardiogenic. How do we do that? We need to see whether the patient is in a pre-shock stage, shock stage, or in a refractory shock stage. I have told you this earlier as well. When we see this patient in this, the parameters which we need to address are the systolic blood pressure, which is one of the definition parameters, the heart rate, the mentation, the lactates, cardiac index if you have a PA catheter in situ, along with the other parameters, and the use of vasopressors. Based on these parameters, we usually assign the patient to a shock stage, or a refractory shock stage. After this, we need to see the lab parameters. So we get the lab parameters along with all of this. We need to see where the patient stands in. And based on this, we need to optimize the patient and see if he's actually deteriorating in the stages upwards, or based on our intervention, if the deterioration is reducing and the patient is improving. You can use the staging to see the response of this treatment as well. So these are the basic parameters that are associated in the sky stage. So it is actually a single picture which helps us understand the treatment modality, both for response and for activation of treatment. So how do we narrow down the diagnosis? Usually we have multiple parameters. You can use ECG, X-rays, lab tests, echo, lung ultrasound, and even cardiac MRI if required. And we also have hemodynamic monitoring, which can be non-invasive or invasive. The focused echocardiographic assessment for cardiogenic shock usually involves assessing the right ventricular as well as the left ventricular function. At the same time, you should also rule out the presence of any thrombus. Then you should ascertain the integrity of the septum, evaluate the valvular functions, both the aortic and the mitral valve, exclude any significant pericardial effusion. Probably this might lead to, you should rule out the possibility of a tamponade. At the same time, also assess the hemodynamic profile using the echo, which usually is measured by VTI, LVOT VTI, diastolic measurements by E prime ratios, and also assess the tricuspid regurgitation, which usually, if there is a severe tricuspid regurgitation, you can cause decreased preload and leading to cardiogenic shock, usually due to the right-sided failure. Also, look at the IVC diameter, and it usually gives a surrogate marker for us about the right atrial pressure status. So, coming to risk stratification for PCI and angiography. So at this stage, if you're finding that the patient has MI, how do you go about? So whenever you have a patient with MI, so what is the possibility that this patient might develop cardiogenic shock? Is there any parameter or a score that can be used? There are two things that can be used. One is the ORB score. The other score is Iabp shock 2 score. So there are various parameters which are used to, prognosticate the patient undergoing a PCI or an angiography. The parameters are age, more than 73 years, previous incidence of stroke, glucose at admission more than 10.6 millimoles per liter, creatinine at admission being more than 132, then arterial lactate being more than 5 millimoles per liter, or a TIMI flow on angiography being less than 3. Usually when the patient are having any of these six variables, they are usually given a certain weightage. Based on this weightage, the patient will be categorized as a low risk category, intermediate risk category, or high risk category. If the score is between 0 to 2, it is a low risk category, intermediate between 3 and 4, and high if the patient is having a score between 5 and 9. So this usually gives us an understanding whether the patient who has undergone a PCI can end up developing cardiogenic shock, because it helps us plan further on better. So other prognostic scores which they've used in cardiogenic shock are SAVE score, Encourage score, Card shock score, and the Iabp shock 2 score, which I've already mentioned. The other one which I wanted to remember is the ORB score. Revascularization is something that we need to address. We've already done the PCI right now after assessing the severity. So does PCA versus CABG have any effect on the outcome? Can anyone answer this? Okay. So current evidence from 4 observational reports comparing PCI versus CABG, the type of revascularization does not, it does not influence on the outcome of the cardiogenic shock. So what is the role of emergent revascularization in acute myocardial infarction causing cardiogenic shock, also known as AMICS? Is there a role for this thing, and what is the name of the trial? Guys, you need to be a little proactive.
So only for the infarct related vessel.
Very good, very good. So what is the name of the trial? It's called the shock trial. Okay. So in the shock trial reported that if the patient undergoes emergent PCI for the particular culprit vessel, there are better outcomes, and this can reduce the incidence of cardiogenic shock. Okay. So what they also saw was whenever you do an angiograph, so the cardiologists are always having some issue finding the smaller blocks, right? So the next question they asked themselves was, what is the role of multivessel PCI versus culprit lesion only PCI? Does anyone know this answer? Probably yes. Someone who answered right now can tell that. So he already gave the answer. So in the culprit shock trial, what they found out was there was no benefit stenting the other vessels which had suboptimal occlusions. So only the lesion which caused the MI should be stented. Rest of the vessels need to be assessed on later basis, and they did not show any improvement or decreased mortality when they did a multivessel PCI. In fact, it showed worsening of mortality if the patient had multivessel PCI at admission. So this is based on the culprit shock trial, that after this, the European Society of Cardiology downgraded multivessel PCI in acute myocardial infarction causing cardiogenic shock from level 3 to level 3 from level 2. So I hope I'm clear about this. So culprit shock trial, treat only the lesion, don't treat other blocks. So what is the goal in cardiogenic shock? What is supposed to be done? So Forrester classification is something that you guys have to know and write this whenever you're asking question. It will help the examiner also know that you have understood the concept, and it will also help you treat your patients better. So whenever you have a patient in the ICU with a cardiogenic shock, the goal is to get them to a Forrester class 1. Okay, in that thing, we need to look at the probable ways that we can do it, whether it is by fluids, is it by diuresis, is it by dialysis, is it by inotropes? That is depending on what the patient's presentation would be. So it's always the sweet point that we need to target. So we have already addressed the etiological therapy. The next thing would be to optimize hemodynamics. And how do we optimize hemodynamics? It can be either by improving tissue perfusion, or it can be improving the pump action. So what do we do for improving tissue perfusion? The best thing would be to do an offloading of congestion. So probably the patient has pulmonary edema, peripheral edema, and probably systemic congestion as well. So these things can be improved by giving diuretics. So tissue here does not mean only cardiac tissue. It also depends on various other tissues like renal as well as pulmonary. The next thing to improve is the cardiac output or MAP. For that reason, we can use inotropes. At the same time, we need to also address coexisting causes which are usually present. That is sepsis if the patient is having acute decompensated heart failure, which is secondary to a septic etiology, or in the patient with vasoplegia because of various other etiologies, even the post-operative period, or even it can be due to any other reason. Coming to improving pump action, we need to optimize the heart rate, and we need to also optimize the contractility. So that needs some amount of beta blockers to optimize the heart rate, and to improve the contractility, we still need to use a inotrope. So where do we start with all of this? So whenever we think of all of this, we need to know what are we treating, whether we need to give fluids first, inotropes first, or we need to directly go ahead with mechanical circulatory devices. So to do this, accurate measurement of parameters is necessary. And this is the only place in the patient with cardiogenic shock, there is an indication still the use of PA catheters. So the use of a calibrated method for cardiac output monitoring for accurate measurement of cardiogenic shock is still gold standard here. So whenever you have a PA catheter, measure all the other parameters like cardiac output, pulmonary capillary bed pressure, systemic vascular resistance, stroke volume. You can also measure the cardiac index and the cardiac power output. So based on all of these data, we can understand where exactly the problem is, and then better treat the patient. So whether the patient needs a particular type of therapy can be, deducted from these parameters. So we have this patient who has undergone a revascularization therapy. So whenever we have a patient and the exam answer, you need to write about management. So you've already come to etiology, classification, cause, and now you have to manage. So when you're writing the management part in your exam, please write it in a certain heading. So that is called as a cardiac grid. So whenever you have any patient or any question, they ask you about cardiology, write it in this heading, and it is called a cardiac grid. So cardiac grid, apart from an MI, if you have MI, write about revascularization. If there is no MI, then you need to address afterload, preload, contractility, and heart rate. Okay. So in our case, if the patient had acute MI, the TIMI-3 is what is the gold standard. If we have stented the patient, then the patient would require antiplatelets along with anticoagulation if required. And the afterload maintenance would be by the use of norepinephrine or vasopressin. And if you feel it is quite high, probably the patient needs inodilators or vasodilators. If the preload is the issue, we need to look at the pulmonary capillary wedge pressure and the right atrial pressure. The usual thing that we need to target is a right atrial pressure less than 10 and the pulmonary capillary wedge pressure less than 15. So if you have these two things, you need to optimize this. So if you have to if the pulmonary capillary wedge pressure is more than 18, probably you need to use diuretics. And if the patient's right atrial pressures are very low, probably you need to use crystalloids to optimize the preload. So if the issue is with the contractility, then you can use a bedside echocardiogram and then calculate the cardiac index. And then based on the contractility of the heart, you can either use dobutamine, levosimendan, noradrenaline, or milrinone. And coming to heart rate, The usual targeted heart rate should be less than 90, less than 110 is what they say. After 110, the heart rate needs to be addressed, because more than 110, it is usually associated with decreased cardiac output. So the drugs which can be used are beta blockers. In case of any arrhythmias, you can use a broader, thing like amiodarone, antiarrhythmic. So after all of this optimization of the cardiac grid, that is the optimization of after-load, pre-load, contractility, heart rate, and revascularization, the question we need to ask ourselves is, based on all of this, did a patient respond? So how will we know that the patient responded? So we need to look at three basic things, that is the cardiac output, pulmonary capillary wedge pressure, and CVP. So the target need to achieve is the cardiac output monitor should show a cardiac index usually more than 2.2 liters per minute per meter square. A right atrial pressure usually less than 10 mm of Hg. The capillary wedge pressure should be less than 15. And a map should be more than 65 mm of Hg. So where did I get this map of 65 mm of Hg? Does anyone know the answer? Is it the same thing for septic shock and this one? Where did we get the answer of 65 for septic shock? Based on which trial?
FCPAM.
Yeah, sepsis pump. Thank you. So that is one thing, but there was no trial which was actually there, and this was actually deducted from the septic shock trials itself. So what they said was achieve a map of more than 65 mm of Hg. And thankfully, in 2022, there was a trial called as the box trial. Okay, so there were box trial, usually it actually abbreviates for BP and oxygen targets for patients with STEMI. Okay, so a box trial is something which looked at BP targets for a patient with a cardiac dysfunction and probable cardiogenic shock. And then what they wanted to notice is whether the use of a target with 63 mm of Hg versus 77 mm of Hg made any difference. And what they found out was there was no difference, but there is a lot of caveats in the study. One of the major caveats is they use a very small target. So the effect size was 10 mm of Hg. So that itself could not, have a major outcome. And the other issue was the use of dopamine as one of the inotrope that they wanted to use. So these two things have been one of the limitations. So if you guys have some time, please read the box trial for both oxygen targets and BP targets. It might come in your critical appraisal. So to read this would not be a bad idea. Okay. So coming to the role of inotropes and vasoactive agents, so we have an armamentarium of drugs here. It starts from phenylephrine, norepinephrine, ephedrine. You can use dopamine, vasopressin, dobutamine, and levosimendan. So can any one of you tell me which is the first line of drug for cardiogenic shock?
Norid.
Very good. Based on which trial? Based on what data? Again, there was no specific study they could do or a head-on trial to prove this is better over the other. But what they saw was there are a few things that we need to consider whenever you're taking inotropes into consideration. The most important thing is whether the inotrope itself can cause a deterioration in the cardiac grid, that is offsetting the myocardial oxygen demand supply mismatch. Okay, so looking at all of these parameters, what they found out was NORAD was the least which can affect that. Okay, so that is the reason they chose that norepinephrine. That is again, after this, they studied norepinephrine versus dopamine, that is in the SOAP2 trial. Again, this was subset data from patients with septic shock. So septic shock patient with cardiogenic shock also present. These patients, when they saw the use of dopamine, they did not get any benefit. So these patients were usually found to have more arrhythmias. So that is one of the reasons dopamine is still not a good drug. So first line, all of you said was NORAD. What is the second line drug? Okay, you have already optimized your NORAD. Patient is still not optimized. This hyperperfusion is still present. Hypotension map targets are still okay, but your hyperperfusion is still there. What do you still want to use? The second line drug?
Dobutamine.
Very good. Dobutamine. What will you keep in mind before you start dobutamine?
Heart rate is below 100.
Heart rate is below 100. Excellent. Apart from that, anything else? One is heart rate, the other one? volume optimization. So if the patient's volume should be optimal. So if your patient is not optimally managed with fluids, probably if you start this, there would be reflex tachycardia setting in, and this would offset the cardiac output, leading again to a worsening map. Okay. So when you're using dobutamine, make sure that the patient's volume status is optimized. Okay. So the other drug is vasopressin. So there is always a debate between vasopressin and dobutamine. Again, heart rate becomes one of the things that is a major factor which we need to use to choose the second line drug. Okay. So what are the roles of levosimendan, milrinone, and other drugs? Do you guys know any trials for milrinone? Okay, is milrinone better than dobutamine? Okay. So actually, by theoretically speaking, phosphodiesterase 3 inhibitors are better compared to dobutamine. Okay. So dobutamine, the major thing is it's a beta agonist. So what usually happens is the systemic hemodynamic effects, which are seen because of a beta agonist, is usually offset by phosphodiesterase 3 inhibitors. Okay, if a patient is already on a beta blocker, to use dobutamine would not be such a good idea, correct? So because we'll not be able to reach the target. So in these patients, they have found out that milrinone is a better drug. So the trial which was done to know the difference, or the thing indications for milrinone versus dobutamine, was DOREMI trial. Okay, so the DOREMI trial said that the use of milrinone usually has a better hemodynamic profile as compared to dobutamine in patients who are already on beta blockers. So this is what you need to remember. The patient population is patients on beta blockers who have developed cardiogenic shock. In patients with such history, you can use milrinone over dobutamine. That is the only thing that we need to take away. So with all of this, I think so you guys are still confused. So we'll look at a few things, which parameter, which clinical indication, what drug to use. Okay, there is no doubt that whenever you have a patient with cardiogenic shock, you start this patient on norepinephrine. So norepinephrine becomes the first line of drug. Okay, so the only thing that you need to remember is the arrhythmia profile and hypertension, which can cause deterioration of myocardial oxygen supply mismatch. Okay, that is one thing which is something that you need to look at when you're using NORED. After that, you can use a dobutamine. Whenever you're using dobutamine, like I've already mentioned earlier, look at the heart rate. And along with heart rate, if you're seeing patients having sepsis-induced myocardial dysfunction, then dobutamine becomes the drug of choice. Usually, the dose which has to be started is around 2 to 20 mics per kg per minute. Okay, so the other worst side effects which are seen with them are tachycardia and ventricular arrhythmias, which usually end up worsening the cardiac ischemia and further deteriorating the cardiac output. So this is one of the downfalls of dobutamine. So this is why we were telling you that avoid tachyarrhythmias. So to avoid that, the basic thing is make sure that the volume status is good, because this volume status, if it is not optimized, it will trigger the neurohumoral pathway. The neurohumoral pathway will cause the activation of all the cardiac reflexes. So that needs to be optimized. See, other things which I've already mentioned, the role of milrinone and dopamine. Dopamine, SOAP2 trial itself said there is no use as of now, so absolutely removed. Milrinone can be used. DOREMI trial is the one which you need to keep in mind. Levosimendan, there are many trials which are used. Mostly, they have not found any major benefit. And the only indication is by an infusion, especially when you have the heart rate being on the lower side. So in such cases, we can use levosimendan. Again, you need to remember these patients on levosimendan can end up having atrial tachycardias, or can have AV conduction abnormalities. So coming to oxygen targets in cardiogenic shock, so the target oxygen which is required is usually around 92 to 95%. So there were two major trials that was given in the picture. That is AVOID trial, which was in 2012. The PICO parameters go in such order. The patient population was patients who had STEMI, okay, and the baseline oxygen saturation was around 94%. So they looked at whether liberal versus restrictive strategy of oxygenation has any outcome on the mortality. So what they found out was there was higher incidence of recurrent MI and increase in the infarct size at 6 months in patients who received liberal oxygen, that is 8 ml per kg by face mask. Okay, so this is something that 8 liters per minute. I'm sorry. So this is something that we need to remember. So a liberal thing is not really good. So this is what was the final outcomes on avoid trial. The box trial usually actually had a very sick population inclusion. The population were out of hospital cardiac arrest patients who were comatose survivors. And the intervention group and the control group was a control group restrictive strategy again, where they received the arterial oxygen that was between 68 to 75 of Hg, and the liberal parameters were between 98 to 105. In this box trial, they did not find any difference between death or disability. So coming to ventilatory support, we have a lot of devices which can give us, oxygen support to these patients. It can range from face mask or nasal prongs and go up to invasive mechanical ventilation. So what is the goal? We should avoid excessive supplementation of oxygen. We all know that in cardiogenic pulmonary edema, NIV or BiPAP is the first level of recommendation. And PEEP and positive pressure ventilation can cause a lot of hemodynamic disturbances. So always monitor your patients closely when you put them on a non-invasive ventilator or an invasive mechanical ventilation, because a lot of changes do happen either because of pulmonary circulation or the changes in the cardiac parameters. That is, they might, in the worst case scenario, because of a lot of issues, there can be loss of ventricular interdependence, which can worsen the hemodynamic parameters that finally leads to decreased cardiac output and worsening of shock. So after all of this, so we have given inotropes, we have revascularized the patient, we have optimized the fluids, we have done everything, and also done a basic supplemental therapy with oxygen. So are the targets met or not is something that we need to know. And if it is not met, the next thing we have to think about is the use of ventricular assist devices. So when do we call the patient as in a refractory cardiogenic shock? So we have, despite optimizing the targets, if you still have signs of hyperperfusion and the patient falls in the SCAI grade D or E, and cardiac index of less than 2.2 and a lactate of more than 2.2, sorry for the spelling error. So these patients get classified as refractory cardiogenic shock, and these patients can be considered for mechanical circulatory devices. So what is the ESC algorithm for cardiogenic shocks, which is saying is, you might be surprised at this. Even I was surprised to see this actually, but after close watching, what they say is use of short-term mechanical circulatory devices in a patient with cardiogenic shock has a class 2A as compared to the use of inotropes and vasopressors, which is class 2B. So there is no right answer when it comes to early initiation of mechanical circulatory devices. Okay, there is no right time. You have a patient with you in the ICU, you have started optimizing the patient. If the patient is not responding adequately and you're seeing that the patient is worsening, say suppose the patient's urine output is dropping, pigmentation is worsening, congestion is worsening by signs of oxygenation, pulmonary edema, etc., probably it would not be unwise to think about mechanical circulatory devices, because inotropes or vasopressors have also not been optimized, or there is no standard rule that they have shown to be beneficial over mechanical circulatory devices. So in such cases, you need to go ahead and think about the use of mechanical circulatory devices. That is when the patient is in refractory cardiogenic shock. If the patient does not want one of these, then the other things that can be considered as palliative care. So in mechanical circulatory devices also, we need to think about the use of renal replacement therapy as well. Sometimes if the patient is only having congestive features causing cardiogenic shock, that might be due to secondary to acute decompensated heart failure, probably ultrafiltration would itself help the improvement of the cardiac contractility by removing the excessive afterload. So in such cases, the patient can benefit. So think about renal replacement prior to initiation of mechanical circulatory devices. But that is a case-to-case scenario. That is the reason we primarily started by telling there is no one-size-fits-all policy for managing cardiogenic shock. So what are the principles of management of mechanical circulatory devices? So this is a pressure volume loop which helps us to understand how the cardiac output is generated usually and what is the stress the myocardium undergoes. So the work which is usually undergoing during a cardiac contraction is the area of the pressure volume loop. Okay, so the labeling here is A represents the end diastole, that is the mitral valve closure. B is the aortic valve opening. C is the end systole, and D is the mitral valve opening. So this is in any normal person. So how does a mechanical circulatory device help? So there are various mechanical circulatory devices which can be ranging for right heart failure or left heart failure. And sometimes even ECMO is also the last resort that we can consider. So here I would like to throw light on only two such mechanical circulatory devices, that is the Iabp and Impella. I will be drilling in detail about Iabp in the next class. And Impella is something that we need to know because there have been a lot of studies regarding Impella in cardiogenic shock. So Iabp, what you need to know is the effect on cardiac work is it offsets the pressure reduction. What you can see here is when the patient is having a decreased cardiac output, the volume is reduced here. And by decreasing the pressure, there is some augmentation of the cardiac output because of the use of Iabp. So this offsets the pressure and thus improves the cardiac output. So that is pressure reduction caused by Iabp. So what usually Impella does is it reduces the volume and the because of which the pressure related changes in the PV loop would be offset. So that is how Impella works. So Impella is usually inserted directly into the left ventricle. Okay, so I'll be dealing with that in the next slide. So what is the selection criteria for a continuous VAD? Usually the patient should have an EF of less than 25%. And usually the oxygen uptake should be less than 12 ml per kg per minute. Okay, so if the patient is getting recurrently admitted to the hospital for an ADHF or a cardiogenic shock, and he's dependent on some sort of inotropic support or a temporary mechanical circulatory device, you can consider for continuous VAD. So Impella and Iabp, this is what you need to know. Iabp, you have the balloon in the descending aorta, and it usually is based on the aortic counterpulsation mechanism, whereas Impella usually is directly inserted into the left ventricle, and it usually offsets the pressure related changes, causing volume reduction. Okay, so major thing that you need to know is Iabp usually depends on the rhythm, so it requires a stable rhythm, which is not required in a patient who has Impella. Okay, and the cardiac output improvement is actually very modest in Iabp, which is roughly around 0.5 to 1 liter as compared to 5 liters in Impella. So Impella usually has a very good improvement characteristics as compared to Iabp if you see theoretically. Okay, but the complication profile is more or less similar in both of them. Both of them are associated with vascular injury, access site bleeding, and coagulopathy. Mortality, if you see both of them together, did not show any major reduction in mortality for cardiogenic shock complicating acute myocardial infarction. So I was mentioning to you, right, there are a lot of mechanical circulatory devices for right heart and left heart. Impella, there is a right heart Impella, left heart Impella, Iabp, veno arterial ECMO, tandem heart. Again, tandem heart, you have a right atrium pulmonary circulation and the left atrium femoral. So this is for right-sided circulation as well as the left-sided circulation. These are the characteristics of all these mechanical circulatory devices. I do not want to go in detail about this because it's quite laborious and I wouldn't see any benefit, but I would like you to understand a few things. So what do we need to know in a patient with cardiogenic shock? Whether there is any improvement in LV unloading and RV unloading, because we are only looking at that, right? Cardiogenic shock is usually caused because of that. So what we can see is LV unloading is majorly done by Iabp, Impella, and the left tandem heart. So this is something that is very good. And one of the reasons why the cardiac output increases up to 5 liters in Impella is because it's directly inserted into the left ventricle. So LV unloading is best seen with Impella. So that is one of the reasons the cardiac power also is better seen in Impella as compared to Iabp. So this is one major thing that we need to know. Coming to right-sided mechanical circulatory devices, again, Impella has not shown major benefit in unloading, but it is still present. Okay, that is something that we need to understand here. Rest, most of them are dependent on a pump mechanism, which is usually an axial type of flow in Impella and a centrifugal type of flow in a tandem heart. And IABP, I've already mentioned, it is a counterpulsation theory. So summarizing the whole thing, we need to know what type of cardiogenic shock the patient has, rule out the causes, look into the possibility of a refractory cardiogenic shock, advise the family for the possibility of a need for mechanical circulatory device. If the patients accept, it is okay. If they don't, please palliate to them at the earliest. And then we need to think about the need for a temporary mechanical circulatory device or a continuous mechanical circulatory device. So this is something that we had to look at, and VA ECMO in patients with cardiogenic shock. When ECMO was compared to IABP, ECMO was considered to be superior, but when it was compared with tandem heart or Impella, they did not show any major benefit. So still, there are a lot of RCTs which is necessary for solid data, which is going to prove the superiority of ECMO in cardiogenic shock. So what are the treatment of non-MI related cardiogenic shock? You should think about VSD closure, pericardiocentesis if there is excessive tamponade, or optimization of RV function, which I'll be coming to in the next class, and surgery for any valvular pathologies. Role of renal replacement therapy, it's only when we are thinking of congestion related cardiogenic shock. Better to use continuous RRT whenever the patient has refractory congestion, oliguria, severe metabolic acidosis, which worsens cardiogenic shock. So as such, there is no survival benefit which has been associated with initiation of early RRT in a patient with cardiogenic shock. So summary of evidence, when we think about mechanical circulatory devices, IABP Shock 2 trial did not show any mortality benefit. IMPRESS trial was something which they compared Impella versus IABP. What they actually saw was Impella may be associated with increased mortality. Again, there was another trial which was recently done, which was called the Danger Shock trial, which they compared Impella versus standard care. And they showed better outcomes with Impella, but there was a lot of issues regarding its validation. Especially there was a lot of patients who was started on Impella before PCI itself. So the lot of confounding which was seen in these cases. So how to interpret this result is something that I leave to the individual listener to go up and read it up. Okay. So ECMO, again, Euroshock trial and ECLS shock trial did not show any mortality benefit. So the last ultimate thing that we can do for cardiogenic shock is a transplant. When all of the above, whichever I've mentioned, fails, the patient is an ideal candidate. Usually the age group depends on individual countries. So roughly if the patient is less than 70 years or 60 years, with better maintenance of other parameters like LFT should be okay. The patient should not have a poor neurological state, good activity of daily living. Then the patient can be considered for cardiac transplant. So this is the summary. Initial assessment, focused cardiac ultrasound, use of inotropes, look into your sky, grading, optimize all those parameters. Think about mechanical circulatory devices at the earliest. If not possible, if the patient is not recovering, better put them on a registry for a transplant at the earliest. Thank you. Any questions? Okay. I hope it was clear. I hope I was not too quick. I'm sorry if it was. Please let us know, guys. We are actually wanting you guys to be more vocal about things like that, because you guys need to understand. If you feel that we are quick in something, please let us know so that we can slow down. We can help you with it. Shall we go to the next one? Okay. So the next topic is intra-aortic balloon pump. So continuing with the talk about cardiogenic shock, I have already mentioned that the patients, who have a very bad LV function, what they were saying that earlier was if the patient had a very bad cardiogenic shock, the survival rate is reduced. But the latest data, what is coming forth is there can be some hope for few patients if you give that temporary support for them, especially post PCI for acute myocardial infarction related cardiogenic shock. So I went through the question bank. The only few things which were there in a few fat papers I could find few, and one in FNB, that is the role of Iabp in cardiogenic shock. Otherwise, you might be asked questions like what is the working principle and troubleshooting of Iabp, indications and contraindications or complications of Iabp. Outline of the talk would be under the following headings. That is introduction.
Darshan,
Sorry, ma'am.
I think it's not been shared. Your thank you slide of the previous talk is there.
Is it? Oh, I'm sorry.
Yeah.
Is it seen now?
Yeah.
I am extremely sorry for that.
Mm.
So coming to the outline of the topic, introduction, working principle, indications and contraindication, mechanics, troubleshooting, and evidence. So we all know that whenever a patient comes for us with cardiogenic shock, we optimize them, look for the use of vasoactive therapy. If they don't improve with that, the next role would be to use mechanical circulatory devices. In this case, probably the use of Iabp if there are no any contraindications. So why do we need to think about mechanical circulatory devices? Why are they having a level 2A as compared to level 2B for inotropes? Because this demand supply mismatch is better optimized with these things, because the major issue in cardiogenic shock at that particular time would be a pump failure. Okay, so in such cases, by increasing the pump and perfusion, we would have better outcomes, is what was the understanding. So again, coming to Iabp, Iabp is a form of internal counterpulsation acting against an assisted circulatory support device. It causes diastolic augmentation during inflation, potentially contributing to the coronary, cerebral, and systemic circulation. Pre-systolic deflation lowers the impedance to systolic ejection, thereby reducing the myocardial work and oxygen demand. And the most evident outcome of this is to increase the cardiac output by at least 1 liter per minute. So this is how it usually looks like. And the person who told about internal counterpulsation therapy was Dr. Adrian Krantowitz in 1959. So what is the basic mechanism? How does it usually work? So the balloon deflation in systole usually causes a decrease in afterload. Because there is a decrease in afterload, there is a decreased wall stress and also the decrease in oxygen demand, which leads to improved myocardial function, which leads to better systemic perfusion. Along with this, when the patient's balloon is inflated in diastole, it also improves the coronary perfusion, which again adds to improvement of myocardial performance. So this is basically understanding the role or the working principle of an Iabp. So there are two things that we need to know: how the pump acts, or how does the balloon inflate and deflate. So what happens in systole is, that is between the QRS and T interval, there is rapid deflation of the balloon, which leads to decrease in the afterload, leading to increased LV stroke volume, leading to decrease in peak systemic blood pressure. So earlier opening of the aortic valve shorter the LV isometric contraction. That is what is achieved in systole. Coming to diastole, that is the TP interval on an ECG, the balloon inflates, causing temporary increase of afterload that causes increase in the coronary perfusion pressure, leading to increased systemic diastolic pressure, or this is called as a diastolic augmentation. Okay, this is what is usually seen in an Iabp. So this is a pictorial depiction of the same. In systole, what we see is the balloon is deflated, because of which there is decreased afterload, decreased cardiac work, decreased myocardial oxygen consumption, and improvement of cardiac output. And this is what we see in the QT interval, okay? And in diastole, it will be the other way around. What happens is there is the augmentation of the diastolic pressure because it's inflated. There is a head of blood which is present in the aorta, which usually improves the coronary perfusion. So by this understanding, increase in coronary perfusion, is it equivalent to increase in coronary blood flow? Can it reduce MI? So the problem is this patient has MI, is unable to go for a procedure. Can we use an Iabp and tell them we'll not put up a stent in this patient? Probably has a 60-70% occlusion. Can you think of this? Have you guys thought of it? Come on, guys, answer something. No? By this diastolic augmentation, there is increase in coronary perfusion, which improves the perfusion of and blood in the coronary vessels. So this itself should be enough, right? In an MI patient with STEMI, we can wait it out. Probably the patient will become better. So what I mean to say is improvement in CPP, that is coronary perfusion pressure, is not equivalent to coronary blood flow, because the intrinsic vascular resistance is also something that we need to understand. So it is not the same. Okay, it's two different things. I hope I'm clear about that. So I've already mentioned this before. There is a pressure augmentation, or there is a decrease in there's a leftward shift of the PV loop in a patient who is on Iabp, which decreases the load on the myocardium and has a better outcome, that is better cardiac output in a patient on Iabp. You can see that there is a baseline condition and unloaded condition. Because of this unloading, there is a leftward shift, there is an improvement in the volume, okay, because of decreased pressure. And that is the reason there is an improvement in the cardiac output. Am I clear till here? Okay. So how do we know about this? Whenever we talk about cardiogenic shock and all of this, we keep talking about myocardial oxygen supply, demand, etc. Right? So if you're seeing an patient on an Iabp, you can still trace something called as the DTPI, which usually stands for the diastolic pressure time index, or the tension time index, which is the TTI. Okay, the TTI represents the demand and the DTPI represents the myocardial oxygen supply. So this is what we are optimizing when we are seeing a patient with a cardiogenic shock with MI. Okay. So what are the indications for Iabp? It is usually used in congestive heart failure with exacerbation with hypotension, prophylaxis as adjunct treatment in high-risk PCI. So MI with decreased LV function leading to hypotension, MI with mechanical complications, patients with acute mitral regurgitation due to rupture of the papillary muscles or VS rupture, that is the ventricular septal rupture, low cardiac output state after coronary artery bypass graft, or it can be used as a bridge to one of these conditions, that is intractable angina or myocardial ischemia, refractory heart failure, intractable ventricular arrhythmia. So when do we use all of this? That is the mechanical circulatory devices when the cardiac index is less than 1.8 liters per minute per meter squared, and SBP less than 90, or a left atrial or a right atrial pressure more than 20 mm of Hg with a urine output less than 20 ml of per hour, which usually indicates the worsening cardiogenic shock. Okay, and a systemic vascular resistance more than 2,100 dynes per minute and presence of metabolic acidosis. So I mentioned that Iabp is used in high-risk PCI. So which candidates are classified as high-risk PCI? Guys, you need to answer. Okay. So patients who have a left main stenosis of more than 70%, left ventricular ejection LVEF of less than 40%, unstable angina postoperatively, patients who undergo redo CABG, that is with stent occlusions or an MI type 4. These patients usually gets classified as high-risk PCI. Okay, what are the contraindications? Absolute and relative contraindications are there. Absolute are significant aortic regurgitation, aortic dissection, presence of aortic stent, end-stage cardiac disease with no other viable treatment option. Usually what we mean by end-stage cardiac diseases, usually they would have some viability scan based on a cardiac MRI or a thallium scan, where we know that there is no viable myocardium left. So in these cases, to put the patient on an Iabp would be detrimental. In fact, they might lead to some amount of mechanical complications like a free wall rupture, etc. So bilateral femoral FemPop bypass grafts, if the patient is there, the patient usually when we put an IABP, it's the femoral root. So if they have undergone a bilateral FEMPOP, probably we cannot do a IABP in such cases. So what are the relative contraindications in patients with uncontrolled sepsis with coagulopathy, abdominal aortic aneurysm, severe bilateral peripheral vascular disease, uncontrolled bleeding disorder, and prosthetic iliofemoral grafts? In such cases, we need to have some amount of caution, and it probably has to be done by an experienced cardiologist. So how does the console look? I think so most of us have already seen this console. Most of us usually would have one of these. Datascope or Mac is one which most of us have in our institutes. So the circuit usually looks like this when they have not inserted it. It consists of a balloon catheter. There is an internal catheter which goes inside and has a balloon. Which is usually connected by a Lock technology to the monitor. Okay, and this is again connected to the arterial pressure transducer and ECG leads along with the console, that is the pneumatic console that consists of helium. Okay, so this is the basic pictorial depiction. What do you usually have is there is the ECG lead and the arterial line from the patient end, which is usually connected to a display monitor. Then that will be connected to the control unit. And the control unit in turn would be connected to the pneumatic system, which usually keeps the intra-aortic balloon pump in motion based on the inputs which are received from the ECG leads and the arterial line. And then the pneumatic system is maintained by the gas source. So I hope it's clear. So the gas source which is usually used is helium. Which other gas is used? Okay, carbon dioxide. So why do we use helium? Because it's inert, it is lower viscosity, increases laminar flow, the Reynolds number is less than 2000, and has lesser resistance. So that is one of the reasons why they used helium. So insertion of the cannula and balloon, first thing we need to measure the length of insertion. So we saw that. How do we do that? From the insertion point to the umbilicus plus the distance from the umbilicus to the sternal angle. This is the way we do it. After that, we need to consider the size of the balloon. The size of the balloon which are usually available in the market ranges from 30 to 50 ml. Okay, the optimal size is to occlude the 90% of the aortic lumen. So that is what we need to achieve. So that is usually based on the height of the patient. Okay, so the length of the catheter usually ranges between 22 to 27.5 centimeters, and it is guided by the height as well. So this is the sizing of the table which we usually use. What we need to look at is probably whether the patient is quite tall or quite short. Okay, less than 6 feet or more than 6 feet. More than 6 feet, usually you need a larger balloon size, probably around 50 ml, and the length of the catheter should be around 27. The balloon diameter is also roughly around 17. So all that you need to know is the balloon should occlude at least 90% of the lumen, and the length is determined by the height of the patient. So how do we insert this? It can be either by a percutaneous technique or an open surgical aortic approach. The IABP is usually done. It is done by a aseptic procedure by Sellinger's method by the use of femoral artery as the approach site. Alternative sites which have been tried are the brachial artery and the axillary artery. Usually it is combined with the dilator and sheath combination, which is usually put into the descending aorta. Various methods of confirming the position is there. That is either by a fluoroscopic insertion or a transesophageal echo. Usually when it is done that, it should be 2 centimeters distal to the origin of the left subclavian artery. So that is the position that you need to have of the tip. So tip is always radio opaque. So that is one of the reasons where the tip can also be seen by a chest X-ray, and it should be ideally present in the left main, near the left main bronchus. That is the second or the third intercostal space. And lastly, one of the least sensitive things would be the pressure augmentation, which is seen with, on the monitor of the IABP. So these are the methods of confirming the position of an IABP. So this is what a console looks like. These are the keypad controls which are usually present. They are the, first the operating modes. You can either use between a semi-auto mode, auto mode, or a manual mode. Or what you can see is the first thing is start at the standby and the zero pressure, which are the main controls. After that, we have a lot of other keys that we can use. That is the triggers. The triggers range from ECG, pressure, etc., which I'll be mentioning later on. Then we have the IABP frequency. Then we have the augmentation keys and the inflation and the deflation keys. Okay, so this is how it looks like. So this is how the monitor looks like. Usually you have the ECG trace going on, you have the heart rate mentioned here, then you have the systolic, diastolic blood pressure and the mean. And once the operation mode is here, the Iabp trace is also present, and then it gives us the inflation of the balloon. The blue line here would actually indicate a graph. So this is how a patient's arterial trace looks like on Iabp. So what you usually have is an unassisted systole, and then you have an diastolic augmentation and assisted systole. There are a few things that I need you to look at. Okay, the first thing is an unassisted systole. Roughly, it corresponds to slightly over 120 millimeters of mercury. So what happens in assisted systole is it is usually lesser than the assisted systole. So if you can see that, that is one thing that you need to observe in the trace. And the other thing that you need to remember is there is increase in the diastolic end diastolic pressure in the assisted aortic pressure. Okay, so the diastolic blood pressure goes, and that there is also a diastolic augmentation which is seen. So diastolic augmentation, assisted systole being lesser than the unassisted systole, and increased assisted aortic end diastolic pressure. These three things are the things which we need to notice in a patient of Iabp. Okay, this is something like a normal trace of an Iabp. So the ideal settings, actually, Weber and Jasniaki are the people who have done a lot of studies, and they've given a few variables. What they've said is balloon position, the closer to the aortic valve, the greater augmentation would be given. Better the balloon occlusion to the aorta, better results of augmentation as well as coronary perfusion pressure. The diameter also is something which is important, because if we use a larger balloon or a smaller diameter balloon, there will be loss of augmentation, which is noticed. Driving gas and timing should be optimal, and it is usually based on the ECG or the arterial trace forms. And if the stroke volume is less than 25 ml, very little diastolic augmentation can be seen. And what they have said is the aortic elasticity is something which drives the overall outcome or augmentation, because in older people, the elasticity of the aorta would be less. So the doubling, which is usually seen between 30 to 90 mm of Hg, would be lost because there is loss of aortic elasticity in elderly. So coming to the triggers, we have the ECG trigger. What I mean by ECG trigger is the Iabp is meant to inflate during the closing of the aortic valve, and it deflates during its opening. The ECG trigger option is the most preferred one, and it is the most reliable one. The R wave on the patient's ECG corresponds to the trigger of deflation. Okay, so the Iabp senses the middle of the T wave for the inflation. So usually we have said before as well, if there is an arrhythmia, it can be detrimental, or it cannot give an accurate augmentation. Probably because of that itself, there might be drop in cardiac output. The counterpulsation which ensues would be lost because of the arrhythmia, and a different trigger option should be usually chosen. Okay, so what you need to understand is R wave triggers the deflation, and the middle of the T wave triggers inflation. So the inflation is during diastole, okay, and the deflation is during systole. So when the patient is having systole, the blood has to come out of the LV and go into the systemic circulation. So you need to have the balloon which is deflated, which causes augmentation of systemic perfusion. And at the same time, during diastole, because you need a better coronary perfusion, it should be inflated so that the volume head in the aorta can be pushed downwards into the aorta, causing the coronary ostia to open and better perfuse the coronary blood vessels. So this is how usually we need to think about it. So the other triggers, so here we said that if the patient has an arrhythmia, we can't use an ECG trigger. What are the other triggers which are present? I've already mentioned earlier, there are the pressure triggers. So if I'm talking about pressure triggers, where do we take the sensor from? So usually it is from the arterial trace form. The dicrotic notch is the place where the balloon inflation is triggered from, and the systolic upstroke triggers the deflation. Okay. This mode can also be used during cardiopulmonary resuscitation. So this is one thing that we all have to practically remember. If the patient goes on to a state of cardiac arrest, we need to change the trigger on the monitor either to auto mode or you change it to manual. And manual, you have to press the trigger as pressure trigger. So this is something that we need to do. Most of our places, we usually run on auto mode, but if not, if you have manual, please change it from ECG to pressure. So what is the other type of trigger? It can be an internal trigger where it is asynchronous, and it can be usually used in a patient with asystole or a patient who is on a cardiopulmonary bypass. Other type of triggers are a pacer trigger. The pacer trigger usually gets in the Iabp inflates with the ventricular pacing spike. Okay. This mode can be safely used when the patient has 100% dependency on the pacemaker. If the patient has some intrinsic cardiac rhythm, probably the augmentation would not be better. Coming to auto mode, in auto mode, the trigger factors keep changing according to the hemodynamic profile as well as any arrhythmia status of this patient. So better to use auto mode. So coming to troubleshooting. So what can happen in a patient with Iabp? There can be a lot of issues, right? It can be either early deflation, early inflation, or late inflation or late deflation. So coming to early inflation, what happens in early inflation is inflation of the intra-aortic balloon prior to the closure of the aortic valve. So because the aortic valve is not closed, what happens is there appears to have a potential increase in the left ventricular end diastolic volume and left ventricular end diastolic pressure, which also can be causing an increase in the pulmonary capillary wedge pressure. So this can cause increase the oxygen demand in the myocardium. So this is the deleterious effect that can happen because of earlier inflation. And the waveform characteristics which are usually seen are the inflation usually comes earlier than the dicrotic notch. So what you see here is the dicrotic notches here, and there's a sharp V here itself. So it actually encroaches onto the systole and causes earlier inflation. Okay, so there is early inflation here. So this is the problem with early inflation. Coming to late inflation, what happens in late inflation is the inflation of the intra-aortic balloon actually happens after the dicrotic notch. So whatever augmentation that is during the diastolic phase that should have happened, which is seen by the faint line here, is missed. And this usually happens after the dicrotic notch. So along with this, the aortic end diastolic pressure also falls down. So there is a sharp loss of V sign here. Usually what you see is the sharp V sign, which was seen in all Iabp traces, that will be lost. Okay. This is not optimal, but you should see a sharp V here. Okay, that is lost. So what are the physiological effects which are usually seen due to late inflation? It is suboptimal coronary artery perfusion. So inflation is something always related to coronary perfusion. So any problem with inflation, either early or late, always remember the heart is suffering. Okay. So coming to deflation, deflation is usually associated with afterload augmentation. So what happens when premature deflation of the intra-aortic balloon? It usually causes during the diastolic phase. So augmentation will be lost. So there'll be a sharp drop following the diastolic augmentation. So this is the sharp drop which is seen, and the suboptimal augmentation for diastole. Assisted aortic and end diastolic pressure also may be equal, or it can be also less as compared to the unassisted one. Okay. So what happens is the assisted systolic pressure may rise. Usually what I told you earlier was assisted systolic blood pressure should be lesser than the unassisted. But here, because of the earlier deflation, assisted systolic pressure would usually go up. Okay, so that will go up, and whatever has to come down comes to the normal level. That is something that we need to remember. So because of all of this, there is suboptimal coronary perfusion. Retrograde coronary perfusion can also be seen. Angina can be certain, and because of all of this, afterload reduction would be lost. So this is something that you need to remember. So assisted thing, whatever the augmentation that has to be received, it doesn't receive it at all. So you can see it is similar to the unassisted beat. Okay, and there is a sharp drop in the end diastolic waveform. And the end diastolic pressure also returns to almost the baseline, which is supposed to be higher up. Okay. This systolic has to come down and diastolic has to go up in a normal waveform. But because of early balloon deflation, what happens is this returns to an unassisted level, and this also goes back to an unassisted level. Okay. So what happens in late deflation? The assisted aortic end diastolic pressure may be equal to the unassisted aortic end diastolic pressure. Okay. So the diastolic augmentation which can be there will appear to be more wider. Okay. So there will be a rise in assisted systole in the prolonged period. If you can see here, this part is slightly pushed up. Okay. Sorry. So this is what happens. So in late deflation, there is widening of the diastolic augmentation, and there is prolonged rise of assisted systole beat, which is seen. And because of this, there is increased oxygen consumption in the left ventricle, and this can impede the left ventricular ejection also. So there'll be heart would be pumping against a lot of resistance in this case, right? The balloon should have already deflated at this state, but LV is fighting against the already intrinsic increased resistance along with a newer resistance by the balloon. So this is one of the problems which we see in late deflation. So remember widening of diastolic augmentation and prolonged assisted systole. So what are the other troubleshooting things that we need to do in Iabp? That is the heart rate. You have a wider plateau, which is seen in bradycardia, but if there is tachycardia, the plateau becomes narrowed. If there are rhythm disturbances, you see alternating wider and narrow plateaus that can show possibility of an arrhythmia. The amplitude of the waveform in the Iabp usually gives us an idea about the blood pressure. So if it is there is an increased height, then it is correlating to hypertension. And if there is a drop in the amplitude, then it is corresponding to hypotension. If there is a gas leak, then what we usually see is the waveform usually falls below the zero baseline. So this is something that we need to be very aware of. And then we need to look at the possibility of a balloon leak there. Okay, the balloon probably might not be good, but might have a rent in it. So catheter kinking is something which is very common, especially in obese patients and patients with multiple lines in situ. That is something that we need to see. If there is rounding of the waveform of the Iabp, then we need to sort it out, and that might be usually because of catheter kink. If there is a sustained inflation, which usually is seen in most of the Iabp machines that we have, it is usually to check the systemic failure alarms. Okay, so it just gives us an idea of the integrity of the balloon. So what do we monitor these patients on? The things which needs to be monitored are anticoagulation, hemodynamics, and patient positioning, along with the routine fast heart beat. So how do we weigh the patient? Weighing will be either based on rate or volume. What do we mean by rate? Is usually we start with the frequency. So when the patient is on a full Iabp support, the frequency would be 1:1. Gradually, when the BP or the hemodynamics are improving, the inotropic supports are coming down, and the patient is better perfused, urine output is better, cardiac output is also good. That time you can start weaning the patient from probably 1:1 to 1:2 and 1:3. Exact timing, there is no mention anywhere. How often we have to check it is also not mentioned. Probably based on the improvement and the requirement of additional support, we can wean the patient. And coming to volume, again, volume base is usually on cardiac output and PA catheter analysis, usually by looking at the activity of the left ventricle. So coming to complications, whenever there are complications that might be systemic complications or procedure-related complications, so mention it while doing the procedure itself, there might be a lot of issues, right? And then when the patient is already on this, so classify your complications and you can write them. What are the bleeding-related complications? It can happen at the access site. It can happen during transfusions. It can also cause some problem secondary to DIC also. So vascular complications can cause limb ischemia, visceral ischemia, and very rarely patients have even had amputation. DVT has also been reported in a few cases. Patient can have infection, possibility of stroke is there, because if that catheter gets misplaced, the circulation cerebral perfusion can be hampered. IABP related mortality has been reported to be roughly around 0.05. Coming to a lot of trials which have been done for IABP, I've already mentioned about the IABP Shock 2 trial, Impress trial, which compared Impella versus IABP. Coming to the reviews, overall, no great benefits. First, one of the earlier trials was Gusto 1, which actually showed 1 year mortality reduction. But later on, a lot of other trials, basically IABP Shock did not show any benefit. So there are a lot of indications with postulated benefits in cases of critical aortic stenosis because there is hemodynamic benefit due to counterpulsation. But these are all postulated and theoretical, but overall outcomes still not very clear. The use of IABP in coronary artery bypass surgery is documented, and there have been cases, and it depends on institutional protocol. No large RCTs present, which can tell that routine use of IABP for every CABG patient has better outcomes. In PCIs, we were talking about the PAMI-2 trial. There was no significant difference in the endpoints, that is death, reinfarction, or new onset heart failure if the patient routinely went on to an IABP, especially the patients with high-risk PCI. Okay, so prophylactic use of IABP, no benefit. So that is one thing that we need to understand. Indications in sepsis, the latest guidelines, there is no role. Thank you. Next, is there any questions?
Sir, is there any timeline? How long do we wait on vasopressor and other optimization therapy before beginning IABP?
See, that's what I told you, no, clearly. When I mentioned about cardiogenic shock, no, there is no data available, or there is no guideline which says that you need to start inotropes and then you can think about this thing, mechanical circulatory devices like IABP. What it says actually is earlier initiation of mechanical circulatory devices in a patient with worsening cardiogenic shock is better as compared to using only inotropes and making sure that the patient improves. There is no cutoff like that. Probably you can start the patient on inotropes. The practical approach would be like that, to start them on inotropes and look for organ failures. Probably the thing that you need to look at is improvement in urine output, decreasing lactates, improving acidosis, probably a decrease in pulmonary edema, decrease in oxygenation. So if all of this is that, you're probably the patient is improving and probably they might not require mechanical circulatory devices. But having said this, if the patient is not improving on them, then the patient might be considered for mechanical circulatory device. But there is no data or there is no guideline which says that start with inotropes, optimize to this particular target of inotropes, and then go to mechanical circulatory device. There is no guideline like that. If you see the previous talk about cardiogenic shock, no, the ESC clearly says that they are putting inotropes and MCS in the same guideline, same line of therapy. Okay, that is the evidence for MCS as of now. But this is whatever I said was for a patient with non-MI related cardiogenic shock. If you have a patient with a cardiogenic shock secondary to MI, probably a high risk PCI patient. Okay, so that time probably you can start this patient on earlier IABP or any other sort of mechanical circulatory device. The other one would be Impella, but if the patient is undergoing PCI, better to put them on IABP. That has shown to have some benefits. So practically speaking, for example, you have a patient who is 73 years of age, probably with an old MI. Patient came to the OPD with a STEMI score. The IABP shock 2 score is roughly around 5 to 6. So these things, you can tell the technician in the OT to keep an IABP on standby. If during the procedure, probably due to revascularization injury, the patient develops cardiogenic shock, that time you can initiate at the earliest. So this is one of the practical things that the cardiologist would think about on initiation of IABP. Hope that is clear. Okay. So I'll hand over the next session to Niharika, and I'll be coming back for RV failure again. Now you can start, I think so.
Thank you, Darshan. Able to see my screen?
You need to, yeah.
Okay. Okay.
The presentation is it open, no?
It's not been seen.
No, I'm just seeing your. The presentation is not open, no?
Okay. Now,
Yeah.
Darshan?
Yes, now it's visible, now.
Okay. Thank you. Okay, so the next topic we'll be covering is the post-cardiac arrest care. This is a very important topic. A lot of confusions are there, so we'll try to clarify all these in this topic now. So, I'm sorry, my slides are not moving.
Yeah, ma'am, it's stuck in the first thing, I think so.
Mhm.
You can stop sharing and reshare again, I think. Just try that, no?
Okay. So the outline of my topic would be introduction, the pathophysiology of post-cardiac arrest syndrome, the etiology, what is actually the post-cardiac arrest care, and two important things I would be discussing in the post-cardiac arrest care, additional to what is each system-wise. Additional things are, one is the targeted temperature management, which has been asked multiple times in the FNB exams. And the other important thing is the neuroprognostication, when to do and how to prognosticate these patients. And it's been asked once in the FNB exams. No, in DRNB, none of these topics has been asked recently. Now, as we know, the survival of patients with out-of-hospital cardiac arrest is actually less than 15%. And when we come in the in-hospital cardiac arrest, the survival is around 22%. Okay, a great proportion of these deaths occur due to resuscitation, basically occur after resuscitation due to post-cardiac arrest syndrome. So what is this syndrome? Basically, after cardiac arrest, when you resuscitate the patient, there is one important thing which happens, that is nothing but the ischemia reperfusion injury. So when this ischemia reperfusion injury occurs in all the organs, that is known as post-cardiac arrest syndrome. Okay, so coming to the pathophysiology, as I told, post-cardiac arrest syndrome, it contains four important components. What are those? First one is the post-cardiac arrest brain injury, post-cardiac arrest myocardial dysfunction, reperfusion injury, and the last one is the persistent precipitating pathology. So, as I told, post-cardiac brain injury, this might happen due to disrupted calcium homeostasis, formation of free radicals, or there will be some altering cell death signaling pathways because of reperfusion injury. And if you cause any additional insults like pyrexia, hyperglycemia, or hyperoxygenation, it might lead to further brain injury. Coming to the arrest-related myocardial dysfunction. This might lead to a stunning phenomenon. There could be global hypokinesia, elevated left ventricular end diastolic pressure. And if the patient doesn't have ACS, there could be a preserved coronary blood flow. Coming to the third component, the systemic ischemic reperfusion response. So this happens due to tissue hypotension, reperfusion injury, due to endothelial activation, any systemic inflammation, which all leads to activating of clotting cascades, and there could be intravascular volume depletion and disturbed vasoregulation, and there is increased risk of infection. And what is this persistent precipitating pathology? So basically, if any other, underlying causes, like if there is an ACS plaque rupture or thrombus formation, if there is any chronic ischemic myocardial scar which is underlying the arrest, any pulmonary embolism or any cardiomyopathies. So what are the phases of post-cardiac arrest syndrome? So basically it is divided into 5 phases, okay? So immediately after the achievement of ROS, to 20 minutes, it is known as immediate period. Then from 20 minutes to nearly 12 hours, it is known as early period. From 12 to 72 hours, it is the intermediate period, post which it is the recovery phase followed by the rehabilitation phase. So important thing is the ROS to the 72 hours, where you have to limit the ongoing injury organ and you have to support the organ systems. And post 72 hours is the phase where you do actually the prognostication of the patient. And if the patient recovers, then we have to do proper rehabilitation for these patients. Okay. Now coming to the etiology of the cardiac arrest. So why is this identifying the etiology is important? Because it can improve the outcomes in the cardiac arrest victims. So, but this is very challenging because these patients are usually in comatose state after resuscitation, and to obtain a direct history in these patients is difficult. Okay. Also, suppose if the patient is conscious, but they could have a retrograde amnesia for the events which have happened, and they might report some non-specific symptoms. So, in any cardiac arrest case, the best way to obtain the information is from the family and witnesses. Also, some physical examination findings may suggest some etiologies of the cardiac arrest. Examples. So, if it is a pulmonary system, so you saw that there is a diminished or abolished breath sounds. If it is unilateral, then you think of pneumothorax or right mainstem intubation. If it is bilateral, you think of pulmonary edema as a cause of arrest. Similarly, in cardiovascular, if there is a new murmur, it could be secondary to papillary rupture or any valve abnormalities. If you feel that there is unequal pulses, as I told, we have discussed, it could be aortic dissection, or it could be any arrhythmias and the causes related to the same. Suppose if in the abdomen there is distension, rigidity, it could be secondary to hypovolemic shock due to hemorrhage. Or if there is a pulsatile mass, it could be secondary to aortic aneurysm rupture. Similarly, in the extremity, if you find a unilateral swelling or there is an erythema, then you think of pulmonary embolism or any septic shock. And if there is a hemodialysis fistula, think of any hyperkalemia. Similarly, if there is sepsis and all, you have skin changes. Neurological also, like stroke or any toxidrome or a hypoxemic or anoxic brain injuries. So these physical findings will tell us some of the causes of the etiology for the cardiac arrest. Coming to the most common causes, this is system-wise, and this is our famous 5H and 5Ts. So hypovolemia, hypoxia, hydrogen ion excess, hypo or hyperkalemia, and hypothermia. These are the 5H. And our 5Ts are toxins, tension pneumothorax, tamponade, thrombosis, which could be either pulmonary embolism or myocardial infarction. Now, what is this post-resuscitation shock? So usually post-cardiac arrest, you resuscitate patient and you usually find the BP is less in these patients. And why does it occur? So it occurs in around 50 to 70% of patients with cardiac arrest. And it is a consequence of multiple organ dysfunction such as MI, renal failure, ischemic hepatitis, and metabolic acidosis. So the factors which relate to this shock include the amount of epinephrine administered during resuscitation. So if they require larger amount of epinephrine, then they might have this post-resuscitation shock. Male genders are more prone to this, shockable rhythms, and time to obtain ROS. So coming to the pathophysiology, why does this occur? Because it is a combination of systemic ischemic reperfusion factors such as myocardial dysfunction, vasoplegia, and hypovolemia. So myocardial dysfunction is very basically it is early and it is a most severe form of shock that is a post-resuscitation patient can present with. Here, the ejection fraction would be transiently very close to 40%, indicating a stunned myocardium. And the vasoplegia occurs due to systemic inflammatory response, which is mediated by cytokines and endothelial dysfunction, which is nothing but the reperfusion injury. Now, coming to the actual topic, the post-cardiac arrest care. So when they ask you the question about post-cardiac arrest care, please try to put this flowchart. So what happens immediately post-cardiac arrest? You have to investigate what is the etiology and treat accordingly. The other additional management which you have to do immediately is, one is the neurological care. Okay, what do? You have to prevent fever, You have to do EEG monitoring and you have to evaluate for neuroprognostication in these patients. Second one is the hemodynamic support. Either you do with either fluids or you do with the vasopressors, inotropes, or if the patient is in hemorrhagic shock, give blood. Okay. Coming to the optimal MAP levels, it is unclear. I will discuss about it in the later slides. Next, coronary perfusion. Okay, do an ECG, see if there is any cardiac etiology like MI and whether you can do a coronary reperfusion immediately. Then coming to the ventilatory adjustments, this is also very important. So protective ventilation should be done, and just monitor your plateau pressures and also the driving pressures. And the last important thing is if the patient survives and improving, then you have to do rehabilitation by involving multidisciplinary follow-up. So now we'll go how each system we need to manage post-cardiac arrest state. Okay. So first is the neurological management. So important things are, you have to see the brain oxygenation part, you have to see the brain perfusion, prevent cerebral edema and the raised ICP. Okay. The post-cardiac arrest brain injury is a common complication and is a major contributor to subsequent death and disability, right? We have seen many patients post-cardiac arrest going into hypoxic brain injury. So basically this post-cardiac arrest brain injury comprises both the primary injury, which is caused by the complete global brain ischemia and initial reperfusion, and the secondary injuries which we might give to the patients like hypoxia or raised ICP or seizures. Also, brain hyperoxia is also implicated as a secondary post-cardiac arrest brain injury. So you need to maintain the normoxia. So in order to prevent the secondary brain hypoxemia, what you have to do is you have to optimize the cerebral oxygen delivery. How? By maintaining optimal cerebral perfusion pressure, maintain arterial normocapnia. Okay, you have to maintain adequate arterial oxygen content while avoiding arterial hyperoxemia. Second, how to optimize the cerebral oxygen delivery? By maintaining the hemoglobin. So if you have to maintain hemoglobin of more than 7 gram per dl and you have to maintain the arterial saturations of around 92 to 98%. Now coming to the map, as I told, there is no fixed map after cardiac arrest that you have to maintain this, but there are a lot of studies which told that better to maintain the map of more than 80 mmHg unless any contraindications are present like an IC bleed or any other hemorrhage. Okay, otherwise better to maintain it of more than 80 mmHg till around the initial 24 hours. Okay, next, in order to see the brain condition post cardiac arrest, better to have a ICP monitoring, either invasive or non-invasive ICU monitoring should be done. And to decrease the raised ICP, either you can use pharmacological and non-pharmacological strategies. But the areas of uncertainty are, what is the optimal timing and duration of this invasive monitoring in patients after cardiac arrest? Whether till the patient becomes conscious or initial 24 to 48 hours. So there is no certainty about that. And second is, what is the target ICP goal in patients after cardiac arrest? It is not like a normal thing which we do, but we don't know the exact target ICP levels in these patients. Now coming to the seizure management. So the most common seizure patterns post cardiac arrest are, one is the myoclonus and the other one is the tonic-clonic seizures. But as we see, more common is myoclonus and also it has a worse outcomes. So in areas where you have a continuous EEG monitoring, better to do it for the 72 to 120 hours post cardiac arrest. If you don't have a continuous EEG monitoring, do at least intermittent EEG, at least one EEG per day for the first 70 to 120 hours. Okay. So coming to the seizure management, standard protocol has been discussed in the last neurology classes. For status epilepticus, it is the same treatment. Okay. And what the treatment goal is, till how much you have to give, I mean, how many days you need to give the treatment is till there is a seizure suppression or a burst suppression for a minimum of 24 hours. Okay, till then you have to treat these patients with anti-epileptics. The reasonable first line agents are valproic acid and levetiracetam. Also, we see a lot of patients post cardiac arrest having myoclonus, right? But EEG doesn't show any evidence of that. Okay, so don't aggressively treat clinical myoclonus. Only if this interferes with any other treatment options like ventilation or something, we need to treat it. Otherwise, please don't treat the clinical myoclonus if there is no evidence of any electrographic seizures. Next, coming to the sedation and analgesia. So what are the goals of sedation and analgesia? Basically, to provide comfort to the patient, to reduce shivering if you're planning any targeted hypothermia, and in order to prevent recall during neuromuscular blockade. So preferably use short-acting sedatives and analgesics because it reduces the duration of mechanical ventilation, time to awakening, and important thing is it helps in, if you give it for a longer time, it may delay the prognostication of these patients. So best to use is propofol, remifentanil or fentanyl. Okay. And if you want to use neuromuscular blocking agents, use it in a limited way because this also delays the neuroprognostication in the patients. So that is about the neurological management. Coming to the cardiac management, as I told, better to maintain a map of more than 80 mmHg unless any contraindications are present. And you need to perform echo as soon as possible to evaluate what is the ejection fraction, okay, IVC, and to rule out any other correctable causes of cardiac arrest. Okay, and if the patient has ongoing hemodynamic management, you have to do serial echocardiography until the patient is hemodynamically stable. Till then, you have to do serial echocardiographies. And you have to individualize the choice of using inotropes, vasopressors, or fluids to treat the post-cardiac arrest hypotension. There is no specific vasopressor or a specific fluid that has to be used in a post-cardiac arrest patient. It should be individualized. Now coming to the monitoring part. So you have to monitor three important things. One is the central venous oxygen saturation if it is available. You have to monitor the myocardial oxygen consumption, which is actually difficult, but we can monitor the lactates, so which helps in monitoring the adequacy of the systemic perfusion and the effectiveness of therapies which is used to treat the shock. Okay. In case of refractory hypotension, you have to evaluate for the need for early mechanical circulatory support devices. Okay. And they say that in patients with no ST segment elevation, okay, and the patient is hemodynamically unstable, better to do early coronary angiography. Okay, it may be still benefit by potentially salvaging the myocardium, and also it decreases the incidence of systolic heart failure in survivors. Okay, so if there is an NSTEMI also, better do an early coronary angiography if the patient is still hemodynamically unstable. Okay, then coming to the pulmonary management. So same, lung protective ventilation. Next, okay, you have to, this is one more important thing. So as we told that we have to prevent hyperoxia, okay, but you can't titrate the oxygen level unless you see something in the monitor. Okay, because post-cardiac arrest, there will be hypotension, the peripherals will be cold, so you'll not be able to get a proper saturation in these patients. So please provide 100% oxygen till you see that you are able to measure the saturations, peripheral saturations. Okay, so once a reliable arterial oxygen saturation is available after ROS, then titrate the FiO2 to achieve an oxygen saturation of around 92 to 98%. Okay, do not titrate down the FiO2 until reliable measurement of oxygen saturation are available. Okay, so if you want to maintain the PCO2, it should be maintained in the normal range around 35 to 45. But if the patient has an ARDS, then you can have a slightly higher PaO2 levels. But maintain the pH. So coming to the hematological management. So same as of any other critically ill patients, if the hemoglobin is less than 7, if the patient has a hemorrhagic, hemorrhage or a hemorrhagic shock as a cause of cardiac arrest, please keep it more than 7. And if the patient has an underlying coronary artery disease, then the transfusion threshold should be higher level, that is at least 9. The other things are usually the normal things. Initiate the DVT prophylaxis either with low molecular weight heparin or a unfractionated heparin. Coming to the GIT system, yes, you have to initiate the enteral feeds as soon as possible. Okay, because since post-cardiac arrest patients are on usually higher vasopressor support, initially start with a trophic feeds and then adjust according to the tolerance. And if they're not able to start the enteral feeding, same parental feeding should be initiated after 5 to 7 days if the patient is not able to take enteral feeding. And give proton pump inhibitor, ulcer prophylaxis, stress ulcer prophylaxis should be given in these patients. But if you start enteral nutrition, then you need not to give this stress ulcer prophylaxis. Infectious disease management. So if the patients are treated with temperature management to a hypothermic target after cardiac arrest, you need to reduce the incidence of pneumonia, for which you can start empirical antibiotics. And do not use CRP or Procal to guide the antibiotic initiation or duration of therapy. Coming to the endocrine and fluid managements in these patients. So, as I told, it depends on the underlying cause. If the patient has MI as the cause, then don't pump him with a lot of fluids. So, see the cause, underlying cause, and then do your volume or the fluid management. You have to balance the risk of cerebral edema with complications associated with hyperchloremia while choosing the intravenous IV fluids. So, as usual, the preferred choice is the novel saline or the RL, which can be used. And do not use bicarbonate routinely in patients after cardiac arrest who have a metabolic acidosis. Only use it in patients with a pH of less than 7.2 or bicarb of less than 20 or AKI stage 2 or 3. And if there is any AKI having life-threatening changes like hyperkalemia or any other life-threatening indications, please initiate RRT. Okay, and do not administer empirical corticosteroids to all patients with cardiac arrest, although supplemental corticosteroids may be helpful in treatment of persistent shock in patients with proven or suspected adrenal suppression. And maintain a normoglycemia in these patients. So this is a slide which is depicting the entire post-cardiac arrest management. Okay, along with this, the important is family-centered care also. So you have to update the surrogates about the condition of the patient. Okay, you have to acknowledge what are the areas of uncertainty in these patients. Okay, you have to make shared decision making. And also, if the patient has having hypoxic brain injury, you need to explain them in detail from the starting of the post-cardiac arrest day itself. Okay. Now coming to the targeted temperature management. So as I told, this is also an important topic. There is a lot of confusion whether to do this target temperature management, what should be the temperature that has to be maintained, whether therapeutic hypothermia is still followed. Okay, so we will see about this. So if you come to early 20th century, they used snow for the survivors of cardiac arrest. Okay, slowly there were lots of trials which were ongoing, and by 2022, the therapeutic hypothermia has become a class 1 recommendation for all the comatose survivors of cardiac arrest, especially due to shockable rhythms. Okay, so what was the therapeutic hypothermia followed at that time was 32 to 34 degrees centigrade. So that is the therapeutic hypothermia that they have followed. Post that, in 2013, there was a trial which had come, that is the TTM trial. Okay, so this trial showed that among unconscious survivors of out of hospital cardiac arrest, so targeted temperature management of 33 did not confer a benefit compared to a targeted temperature of 36. Okay, so till then, everyone followed this, that there should be a therapeutic hypothermia. But when this TTM trial has come, so now there was a question arising whether really we require a therapeutic hypothermia or what. Post that, there were a lot of trials, okay, like a Frost trial, Hyperion trial. Everyone showed that there was no much significant benefit with 33 degrees centigrade. And in fact, there were a lot of complications which happens like arrhythmias with hypothermia. So then till 2019, everyone still followed the same. And if you come to the guidelines, before this TTM2 trial, Okay, our AHA guidelines 2020 also say that it has a class 1 recommendation for TTM to maintain a core temperature between 32 to 36 for at least 24 hours for unresponsive patients after out of hospital as well as in hospital cardiac arrest. Also, the European Resuscitation Council in 2021 also recommends that TTM with 32 to 36 degrees centigrade for at least 24 hours. Okay. So this is till 2021. So in 2021, we had this TTM2 trial, which showed that there is no difference in survival at 6 months and also no difference in survival with severe disability in comatose patients who received TTM to 33 compared to the targeted normothermia, that is 37. Okay. Post which you have one more trial, the capital chill trial also showed the same thing, that there is no benefit with 31 versus 34. Okay. So this is basically the TTM2 trial. They might ask it in your exams. So this was basically an open label trial where adults with coma who had out of hospital cardiac arrest has been grouped into two things. One is targeted hypothermia at 33 degrees centigrade, which is followed by controlled rewarming. And the second one is the targeted normothermia with early treatment of fever. That is, if the temperature is more than 37.8, then you treat the fever. Otherwise, you maintain the normothermia. So they've compared these two things and they have seen that primary outcome was death from any cause at 6 months. Okay. And if you see, there was no statistical significance in the primary outcome. Whereas when you come to the secondary outcomes also, there is no much significance. But when you come to the serious adverse events, okay, like arrhythmias, which results in hemodynamic compromise, was much in hypothermia group, okay, around 222 people, that is, and here 152 people. So it is very much statistically significant. And that was the cause of death actually in these patients. Okay, so then the TTM2 trial told that there is no much significance and better to avoid. So what did they conclude? In patients with coma after OHCA, targeted hypothermia did not lead to a lower incidence of death by 6 months than with targeted normothermia. So now we have to wait for the next guidelines, 2025 AHA guidelines. We have to see what will they include in this, whether they will change their norms or they will continue. We will see for the same. Now coming to the pros and cons of this TTM. Okay, so what are the pros? So basically, I told in post cardiac arrest syndrome, the ischemic reperfusion injury is the main pathophysiology, right? And this targeted hypothermia or the TTM will prevent this reperfusion injury. That is the only theoretical benefit which is present. So there is mitigation of ischemia-induced neural damage plus possible neurogenesis and gliogenesis, which may lead to improved neurological outcomes and improved functionality post-cardiac arrest. But this is just theoretical. But coming to the cons, there is longer ICU stay, there is delayed awakening, lot of infections, pneumonias, ventilator-associated infections or pneumonias, arrhythmias, electrolyte imbalances, hyperglycemia, and coagulopathy. And if you come systematic effects of targeted hypothermia, so only important thing is neurological benefits are there. Other than this hypothermia may lead to seizures, but coming to cardiac effects, it may cause conduction abnormalities, prolonged QTC, it may cause decreased cardiac output, increased lactate levels, or if you come to musculoskeletal system, increased chances of shivering. Pulmonary effect, it leads to pulmonary vasoconstrictions. Hematological effects, impaired coagulation. Renal effects, there could be electrolyte imbalances or there could be caliuresis. Okay, endocrine, there could be decreased insulin secretion and increased insulin resistant, which results in hyperglycemia and increased chances of all types of infections in case of hypothermia. Except for the neurological, which has some positive effect, all other system effects are usually negative. Okay, so coming to the trials, so there are a lot of trials. As I told in 2000, if you see here, yeah, 2021, I told this is a recommendation, right? Because of these two landmark trials. What are those two landmark trials? One is the hypothermia after cardiac arrest group. This is one study, and the Bernard et al. Has published one more study. Both are RCTs, which showed that there was a significant lower death rate and favorable neurological outcome in hypothermia group. Here also, hypothermia group had higher rates of survival with favorable neurological outcome. After these two trials, in 2022, they told that this is a class 1 recommendation. The targeted hypothermia is a class 1 recommendation. Post that, from 2010, there are lots of studies which has been done. Okay, and everything showed there is no significant difference in survival to discharge or any neurological outcomes. And the most three important trials are the Hyperon trial, the TTM1 trial, the TTM2 trials, and the Capital Shield trial. All these trials showed that there is no significant statistical difference between both the groups, and the complications with hypothermia are actually more. Now, these all trials are in out-of-hospital cardiac arrest. But when you come to in-hospital cardiac arrest, is there a role of TTM? Okay, so in general, patients with IHCA have more favorable neurological as well as mortality outcome because there is rapid detection of this arrest, and also there are highly trained medical professionals in the hospital compared with out-of-hospital cardiac arrest to take care of these patients. So there was one multicentral observational cohort study done by Chan et al. And they showed that patients both shockable as well as non-shockable rhythm in hospital cardiac arrest, if you give hypothermia, it was associated with a lower likelihood of survival to hospital discharge. Also, there is lower likelihood of favorable neurological survival. Okay, so it didn't benefit much. But this was an observational study. Later, if you see the subgroup analysis of this Hyperon trial, which I was telling, there was some 25% of patients who has a non-shockable rhythm and an in-hospital cardiac arrest. And actually, it showed that there were better outcomes when compared to patients with out-of-hospital cardiac arrest if you give a targeted hypothermia, but it was not statistically significant. So we don't have much of trials on IHCA, but whether to give the TTM or not is still in doubt. So I told 2021, the European guidelines have told that you have to maintain to 32 to 36 targeted temperature in post-cardiac arrest patients for at least 24 hours. Post this TTM2 trial, the guidelines have been changed a bit. So in 2022, they have recommendations for temperature control after cardiac arrest in adults. They have recommended some things. So what are those? So they tell that you have to do continuous monitoring of core temperature in patients who remain comatose after ROS from cardiac arrest. And there is a low recommendation for preventing fever in post-cardiac arrest patients. Also, you have to actively prevent fever for at least 72 hours in post-cardiac arrest patients who remain comatose. Don't take only initial 24 hours. You have to prevent fever for the next 3 days after cardiac arrest. Okay. And they tell that there is currently insufficient evidence to recommend for or against temperature control at 32 to 36 degree in subpopulations of cardiac arrest patients or using early cooling. So hence, future research may help to elucidate this. Okay. And we do not recommend using pre-hospital cooling with rapid infusion of large volumes of cold IV fluid immediately after ROSC. Okay. So basically they are telling that still this is doubtful, but at least maintain normothermia and just prevent fever for the next 3 days post cardiac arrest. Okay. That is the ERC recommendations. So this is about targeted temperature management. I didn't go in detail how to cool a patient because still this targeted hypothermia now is not a concept at all. And suppose if the patient post cardiac arrest has a temperature of around 36 or around 35, mild hypothermia, do not treat it to make to a normothermia. You can accept that 36 to 35 mild hypothermia can be accepted post cardiac arrest. Don't rewarm the patient to maintain a normothermia. That has to be kept in mind. Now, the other important thing is about the neuroprognostication in comatose adult survivors. Okay. So, before neuroprognostication, we should keep some important points in mind. What are those? First, you have to allow sufficient time to pass so that the confounders can be excluded. Okay. So you have to give a minimum of 72 hours post ROSC. Then do your prognostication. Either you do whatever tests you want, you have to do it post 72 hours after cardiac arrest. Okay. And suppose if the patient is on therapeutic hypothermia, you have to rewarm the patient. Post rewarm, you have to wait for 72 hours and then do the prognostication in these patients, right? If you are not doing any therapeutic hypothermia, you post cardiac arrest patients, you can do the neuroprognostication 72 hours post cardiac arrest. But if you're doing any targeted temperature hypothermia, you have to rewarm the patient. Post rewarming, you have to do the neuroprognostication 72 hours post rewarming. This is the important thing. Now, as we know, if we give sedatives, neuromuscular blockers, or any drugs are there, any toxic drugs has been taken, some time has to be gone to, we have to see about the half-lives in these patients. So we have to wait for at least 5 half-lives to ensure that the drug is fully cleared. Okay, but if you're giving any infusions like propofol infusion or anything, you have to see that the context-sensitive half-lives of the sedatives has to be removed or has to be gone. Then only you can think of neuroprognostic these patients. So in patients with acute kidney injury, if concerns exist regarding uremia or drug clearance as a potential confounder, a trial of renal replacement therapy should be considered, and then you think of prognostifying these patients. Okay, and if you have any drug testing the drug levels if available, you have to do the same to ensure the clearance. So how to evaluate these patients? When to do what? Okay, so the patient has achieved a return of spontaneous circulation. So on day 1, what do you do? Okay, so initiate target temperature management according to the present guidelines which are present. Okay, 32 to 36. Okay, then you have to do, if you there is an availability of continuous EEG monitoring, you have to start. If not, at least you have to perform the intermittent EEG monitoring. Okay, and you have to consider expert consultation for any post-cardiac arrest management and neuroprognostication. So first 24 hours or less than 24 hours, you have to manage the temperature part and EEG monitoring. Day 2, okay, what you have to do, if you have done TTM, you have to begin rewarming. Okay. Day 3, what you do is you have to completely wean off sedation if the condition permits. Okay. Then post 48 hours, you can do a CT non-contrast. Okay, and if you have in your institution, better to do a SSCP level also, and if the clinical condition permits, you can do an MRI diffusion weighted imaging also. Okay, so day 1 TTM, day 2 rewarming, day 3 wean off the sedation and try to do some neuroimaging. Okay, now day 4 is the time where we think of actually starting the actual part of prognostication. So that only, if I told if there is therapeutic hypothermia was not used, you can start the neuroprognostication. If the therapeutic hypothermia is used after rewarming, post 72 hours, you have to do that. So what you have to do is you have to document the EEG findings of sedation. Okay. And you have to discontinue if there is no seizures. EEG monitoring can be discontinued if there are no seizures. But if there are still seizures, then you have to continue the EEG monitoring till you find there is a burst suppression or there is a resolvement of seizures. 12 hours, for 12 hours. Okay. And you have to monitor the pupil examination, motor examination has to be monitored on day 4 and day 5. So this is how you evaluate a patient, okay, post cardiac arrest. Now, how to prognosticate? I mean, what are the indicators which tell that the patient had a good prognosis or patient has a bad prognosis? Okay, so same. After achieving, Okay, so after achieving ROS, so you have to see whether the patient follows your commands. That is, patient is conscious or not conscious. If the patient is able to follow your commands, then awakening from coma, yes, patient has a good prognosis. But yes, most of the patients will not be awake. Then you have to see whether the patient has any neurological criteria for death. Okay, for this, you must wait 24 hours following rewarming to 36 and the patient should be free of sedation. Okay. So after this, if the patient meets any neurological criteria for death, yes, death by neurological criteria. Okay. If no, then you have to see whether the patient has any predictors of good outcome. So what are those? First, if the patient has any motor response withdrawal or localization, that is one thing, or this is motor response, or you can do an MRI, and MRI shows there are some just small lesions, small or absent or small isolated DWI lesions. Then you can, or if you do an EEG continuous background, okay, EEG continuous background of less than 12 hours from rock, or if there is a reactive background of less than 24 hours, or if you see the amplitude of SSEP of greater than 4 microvolt for more than 48 hours, then you can say that patient has an indeterminate outcome, but he might require a longer period of support or continued observation for awakening. Okay, so if these are present, then okay, patient might have a good outcome in future, but it could take some time. But if patient doesn't have this, then you have to see whether the patient has a predictors of poor outcome. Okay, what are those? If there is an absent pupillary right response bilaterally, okay, for more than 72 hours, then it is a poor outcome. Or if your SSCP is SSCP is available, so if there is bilateral N20 absence for more than 48 hours, then this is also patient will be having poor outcome. Okay. If these are not present, okay, so first is good outcome, present, very good. If it is poor outcome, yes, you have told that patient has a poor outcome, very likely, but some uncertainty exists. But if the patient has moderately reliable predictors of poor outcome, okay, what are those? If you see that CT of more than 48 hours will show some diffuse patterns of loss of gray white matter differentiation, of there is sulcal effacement, or if you see that the MRI DWI shows some diffuse pattern of restriction, or if the EEG shows background suppression or burst suppression, okay, then patient has a poor outcome which is likely, but significant uncertainty exists. If there is no, then same, the patient might have indeterminate outcome and he might have a longer period of support and observation is required. So this is how you actually prognosticate a patient. A little difficult and little bit confusing, but please go through it once again, then you will understand it properly. So this is the last slide, which I've just put. If you have time, you can go through how do you do neurological examination, means if pupillary light response, how do you do it? Okay, what is the interpretation that you can think of, and what could be the outcome, predicted functional outcome, what it could be. So everything is, it's not so important, but for your knowledge wise, I've just put this slide. So if you have time, you please go through this once. Okay, thank you. If you have any doubts, you please post it in the chat box. Darshan?
And thank you, ma'am.
Okay.
I think so. There are no questions, so we'll go ahead with the next topic, if that is the thing. Is my screen visible?
Yeah, Darshan.
Okay. Okay. So, hi everyone. I think so. That was a very exhaustive talk on post cardiac arrest care. It's important in a lot of topics, I think so. It's both in the practical scenario as well as the theory. So it was quite extensively covered. So going on from that to another question which has been frequently asked in the exams, that is the right ventricular failure diagnosis and management. So this is one of the things which I've been seeing more often in both the FNB and the DM questions, but DRNB, I think so very soonly we'll get it. So coming to the outline of the topic, it goes under the following headings, starting from introduction, pathophysiology, risk factors, clinical presentation, workup, management, and what are the evidences. So introduction, there is no universal definition of the right ventricular failure like the other causes which we have already mentioned, like cardiogenic shock, etc. But now we have come to some consensus. But for RV failure per se, there is no classical definition. Phenotypically, it is different from left heart failure. That is what we need to understand. There are certain peculiarities of the RV which is different as compared to LV that changes the pathophysiology and the outcomes in such patients. So firstly, we need to know what is the major difference between the right ventricle and the left ventricle. I know this is a quite busy slide, but what I want you to look at is structurally, the right ventricle is a thin-walled structure as compared to a thick-walled left ventricle. The supply, that is the coronary blood flow, is usually less in the right ventricle as compared to the left ventricle. The oxygen extraction is also comparatively lesser, probably because of the thinner the structure of the right ventricle. So given these things, the sensitivity of the right ventricle is more to a pressure overload state as compared to a volume overload sensitive left ventricle. Okay, so these three things are majorly the ones which are different from a right ventricle and the left ventricle perspective. So we all know that the cardiac output is determined by two major things, that is the stroke volume as well as the heart rate. So the determinants of the stroke volume is usually the preload, contractility, and the afterload. And the preload is usually determined by the compliance and the filling pressure. So you need to know that the heart is a double power generator. That is, both the LV and the RV propel blood into circulation. And this is well adapted and it is synchronous. And this is called as ventricular arterial coupling. Okay. So under normal conditions, the RV is coupled to a low impedance pulmonary vascular system and to the right-sided pressures that are lower, usually lower than the left-sided pressures. Okay. So the unique physiological and anatomical features of the right heart make it extremely poor and poorly tolerant to pressure overload states. Example like a pulmonary embolism. So sudden increase in pressures are poorly tolerated by the right heart. In contrast, the left ventricular myocardium, it is thick. It is well adapted to high pressures because it has to pump against the systemic vascular resistance. So the response of the RV and the LV in experimental cases is something like this. Okay. So what they looked at was how does the RV respond to a change in pressure as compared to the LV. You can see there is a precipitous drop in a small increase in change in pressure in the right ventricle for the stroke volume. From 100%, it just drops just by an increase in 10 millimeters of mercury. Whereas you see for an increase in 10 millimeters of mercury, LV is fairly okay. It's not 100%, but it is fairly above 90. But if you see for a change of more than 20%, RV precipitously drops the stroke volume. So it is that very sensitive to changes in pressure. So this is how it looks like in a cross section, the heart, okay, the right ventricle and the left ventricle. And what happens in a pressure overload state is usually the RV becomes more compliant. RV, because of its thin-walled nature, is more compliant and can accumulate a lot of fluid. So in a fluid overload state, the RV accumulates the excessive fluid. Slowly, it pushes onto the septum, and then septum can be indented towards the LV. This LV and the RV septal differentiation and maintenance is what is called as septal or ventricular interdependence. Okay. In the normal case, it is usually the LV which propels blood forward against the systemic vascular resistance and gets a proper cardiac output. But in case of a dilated RV, the LV gets compromised and the cardiac output can drop, and thereby losing the ventricular interdependence. Okay, so what is usually seen in a right ventricular dysfunction state is the RV impinges on the septum, causing a D-shaped LV, and that D-shaped LV does not accommodate a lot of volume. That is, it causes a reduction in the left ventricular end diastolic volume, an increase in the left ventricular end diastolic pressure, causing drop in cardiac output. Similarly, what you can usually understand is by an example. So let us take an example of pulmonary hypertension. Okay. So initially what will happen if the patient has developed pulmonary hypertension for any cause be it any vasculopathy or an idiopathic cause, or probably due to an ARDS, or probably because of an interstitial lung disease, what usually happens is the pulmonary vasculature causes an increase in resistance. Because of the increased pulmonary vascular resistance, the RV usually tries to compensate. Okay, and the LV load is usually offset by the increase of function of the RV. Okay, slowly what happens is the muscle contractility is usually coupled with the wall thickness of the RV. So RV wall thickening starts happening when there is persistent increase in the pulmonary vascular resistance. Slowly what happens is there will be a dilation which is seen after a certain amount of time. There will be no further increase in the thickness, and it usually causes dilation of the right ventricle. If at this stage the right ventricle is not taken care of, what we can see is there is septal impingement on towards the left ventricle, and this can reach a critical failure where usually the ventricular interdependence is lost. So this is usually the chronology of events which causes the changes in RV failure. Okay. So coming to the pathophysiology, as I've already mentioned, first let's start with RV dilation. So whatever I've shown you here in the previous slide is we have already reached the setting where the pulmonary vascular resistance has not been taken care of, and the patient has already ended up in a right ventricular dilation. So because of the right ventricular dilation, there can be two things which can happen. RV is dilated. So when RV gets dilated, there is tricuspid insufficiency, increase in the right atrial pressure, which can cause congestion in the systemic circulation. Similarly, because the RV afterload is also increased, that is due to probably a pulmonary pathology, there is decrease in RV stroke volume, decrease in RV cardiac output. Later on, it can worsen these things when the ventricular interdependence is lost and also lead to decrease in coronary perfusion. In the same way, because of the dilation of the right ventricle, there is increased transmural and pericardial constraint, which causes the leftward shift of the septum, which causes drop in cardiac output and which leads to drop in blood pressure. So this is usually the pathophysiology associated with RV failure. So coming to the mechanisms and causes of RV failure, it is usually due to increased afterload, reduced contractility, abnormal preload, altered ventricular interdependence, or an altered rhythm. So you can easily understand by this cartoon. You have the left lung, the left heart, the right heart, as well as the pulmonary vasculature. So change in any of these parameters, that be the rhythm, be the preload, the contractility, the interdependence, or the afterload, can cause RV failure. So RV failure can be due to two things. One, it can be an acute event, like in case of a pulmonary thromboembolism, or in the case of a large right ventricular infarct. Or else it can be chronic, which is usually associated with pulmonary hypertension and acute decompensated heart failure. So stages of RV failure include systemic congestion, hypoperfusion without frank hypotension, but if it's not checked in these two stages, can lead to a precipitous event which causes hypotension and shock. So the vicious cycle usually involves three major systems, that is congestive hepatopathy, nephropathy, and encephalopathy. And usually it's because of either congestion or hypoperfusion, similar to what is seen in cardiogenic shock. So the signs and symptoms of RV failure are weight gain is usually seen, poor appetite and GI intolerance because of congestion, and the patient usually has exercise intolerance. The systemic congestion, when you see, is usually due to raised JVP. That is one of the signs you see. Peripheral dependent edema and congestive hepatomegaly. The signs and symptoms for hypoperfusion are cold extremities, decreased urine output, and altered mental status. So usually it starts with the failure with some, trivial signs like loss in appetite and exercise intolerance. If not checked in, it goes into the further stages, leading to a multi-organ involvement. So hepatopathy, when it is present, the patient usually presents with right upper quadrant pain, icterus, flaps or asterixis, anorexia, cachexia, and positive hepatojugular reflex. On the labs, you can see unconjugated hyperbilirubinemia, a SAG ratio of more than 1.1 grams per deciliter, mild transaminitis is what is usually seen, and LFT might indicate a cholestatic picture. So RV failure causes increased unconjugated bilirubin that causes ascites. Ascites, if not checked on time, can lead to increased intra-abdominal pressure, can lead to intra-abdominal hypertension, can lead to renal dysfunction. So usually hepatopathy and nephropathy go hand in hand, as seen with any chronic liver disease states. Encephalopathy is majorly because of hypoxia and metabolic causes, can be associated with asterixis, delirium, and seizures in worst case scenarios, and can be seen in patients with cardiorenal syndromes, usually post an AV fistula, or when the patient has been initiated on a hemodialysis. In severe cases of PAH, when the patient is not treated properly, if the foramen ovale is not patent anymore, there can be a paradoxical embolism leading to stroke. Renal dysfunction, as I've already mentioned before, is because of poor perfusion. It can be caused because of shock. It can be caused because of increased Iabp, both. Okay, so it is initially because of our LV dysfunction, and later on, if RV also, initially starts with RV dysfunction, and later when LV gets involved, it goes to a worst case state. So usually what is seen in these cases are AKI is usually diagnosed based on the critical criteria itself. And when we are thinking about cardiac origin, look at proteinuria and raised brain natriuretic peptides. Cardiorenal syndrome is usually an organ crosstalk, which is usually seen because of both left heart and right heart dysfunction. The pathophysiology involved here is because of poor perfusion. That is due to altered RAS pathways and activation of other neurotransmitters like bradykinin and prostaglandin, which usually causes decreased renal perfusion and vasodilation and natriuresis. That causes a drop in GFR and further causes intrinsic renal disease. So this is something that the primary thing has to be treated for us to have better outcomes. There are a lot of types. I mean, there are 4 types of cardiorenal syndromes that needs to be tackled. Okay, I'm not going to detail of this because that is in itself a separate topic. Relevant lab investigations that needs to be done in an RV failure is baseline creatinine, bilirubin, which usually indicates unconjugated hyperbilirubinemia. Sometimes you see mild transaminitis on an LFT and a cholestatic picture. BNP, as I told you, will be high, and high ascitic fluid analysis. Lactates, as usual with any state with a cardiac failure, is elevated. What are the ECG changes which are seen in RV failure? As I've told you earlier, ECG changes are something to determine or help us understand the acuity of the event. What I mean by acuity is whether it is due to an acute event like pulmonary embolism or a chronic event like a pulmonary hypertension causing RV failure. So what are the signs of acute right ventricular failure which are seen in an ECG? Are complete or incomplete RBBB, terminal right axis deviation, prominent terminal S wave in lead 1, and a prominent S wave in V6. So usually what is seen is there is no S wave in V6. So if you see this, then probably you need to think there is an acute right ventricular strain. What happens to the T wave morphologies? You see right precordial leads, T wave inversions, inferior leads, which is usually more in lead 3 as compared to AVF. And the STT changes are seen in extreme cases, usually associated with the RV myocardial infarction. So this is something that we need to keep a close watch on. And sometimes what it can mimic is a posterior myocardial infarction. So whenever you see STT changes, especially in lead 3 AVF, antereceptal leads, or a diffuse ST depression in AVR, probably you need to think about a posterior MI as well. So not just an RV failure. So what does the ECG changes which is seen in chronic right ventricular hypertrophy? The R wave is tall in V1, which is usually defined as R more than S, or R being more than 7 millimeters, highly specific for RVH. The terminal right axis deviation is seen, which is associated with S1, S wave in lead 1. And what I mentioned earlier, that is V6, where usually the S wave is absent. Right atrial abnormalities, right strain patterns like T wave inversions in V1 to V4 are seen in lesser degrees when we see that. Okay, so we need to think about these 2 things: ECG changes in acute as well as chronic right ventricular failures. So what is the role of 2D echo in RV failure? So we have a lot of idea because recently we completed a class on pulmonary embolism. So I think so you guys know about what is TAPC, what is RV dilation, what is 60-60 sign, all of this. So these are the things which have been usually attributed changes of echocardiographic features of RV failure. So there are various things which are mentioned here. We can see RVMI usually starts for right ventricular myocardial infarction, acute PE, left heart disease associated pulmonary hypertension. That can be both pre and post capillary pulmonary hypertension and chronic pulmonary hypertension. So the various echographic parameters which are mentioned are RV dilation, RV hypertrophy, left atrial and ventricular dilation, septal shift, RV hypokinesia, drop or decrease in TAPC, congestion of the IVC, LV, E by E prime ratio, presence of pericardial effusion, and the pulmonary arterial systolic notching, which is usually seen in acute PE. So these are the few things that we need to assess when a patient comes with RV failure. So if the patient has right ventricular MI or patient has a pulmonary hypertension pitches, we usually see the RARV dilation. So any right ventricular pathologies, we usually see a chamber dilation. The ratios I will mention shortly. What we usually can differentiate between pulmonary hypertension and acute PE is hypertrophy. Because it is acute in event, the hypertrophy is not present in an acute pathology. But if you see a hypertrophy in the RV, that is usually due to pulmonary hypertension. So left atrial dilation, septal shifts can happen in both acute and chronic. It is only the compensation which is lost in the RV that leads to a septal shift. RV hypokinesia can be global or regional. In acute PE, it's regional, and the sign which is most commonly seen is McConnell sign, that is regional. Apical sparing is what is usually seen. TAPC, I'll be discussing further in the next coming slides, even the IVC parameters. IVC parameters, usually because of congestion and failed RV, it is usually dilated, probably more than 2.2. So this is something that we need to keep in mind. Okay. Presence of pericardial effusion is usually seen in chronic states as compared to acute states. So whenever you have to delineate or differentiate between acute and chronic, look for hypertrophy, look for pericardial effusion. If you can see these two things and probably regional hypokinesia, these things will help us differentiate between acute events as compared to chronic events. So what is RV dilation? Usually what is seen is in a normal RV, that is usually 60% of the size of the LV. When there is moderate RV dilation, it almost is equivalent to the LV. But if you feel that RV is greater than the LV, then that is severe RV dilation. What is septal flattening or the D sign? Usually septal flattening in diastole suggests volume overload state, especially in severe pulmonary hypertension. This leads to impingement of the septal wall or a crossover to the left ventricle, which has been attributed both to volume and pressure overload states. Coming to TAPC, TAPC is an acronym for tricuspid annular plane systolic excursion. So the measurement is usually a two-dimensional apical four-chamber view. The M-mode cursor is what is used for the lateral annulus of the tricuspid valve, and it is usually measured for the annular motion around the valve longitudinally during systole. So the grading starts from the four gradings. That is, normal value is usually more than 16 to 20 millimeters. Mild dysfunction is usually between 11 to 15 millimeters. Moderate dysfunction is 6 to 10, and severe dysfunction is when the TAPC is less than 5 millimeters. The echo findings in pulmonary thromboembolism have already been mentioned, but I'm just going into a few of the major things. Because it's an acute event, what you usually see is an RA-RV dilatation with the RV to LV ratio of more than 1 with the McConnell sign in the four-chamber view. There might be a D sign which is present. There is something called as the 60-60 sign. The 60-60 sign refers to the acceleration time of the pulmonary ejection as compared to the tricuspid systolic gradient which is seen. So usually that is 60 milliseconds, the presence of a notch in the pulmonary ejection as compared to the tricuspid jet, which is seen in the tricuspid valve area. So that is the 60-60 sign. Okay. So that is one of the other thing. Other ones which are usually seen associated with pulmonary thromboembolism is TAPSE and tissue Doppler imaging, usually showing a change in the E and A waves. Usually there is decreased velocity of the S wave less than 9.5 centimeters per second. What are the other imaging modalities that can help us understand right ventricular failure better? Probably to majorly evaluate the cause for RV failure, we use a CT. CTPA is best used if you want to think about pulmonary embolism. Otherwise, if you're thinking of a primary lung pathology causing right ventricular failure, secondary to pulmonary hypertension, probably CT is a best imaging. What usually additional things that can be seen are the RVLV diameter dilatation of the pulmonary artery. If there is any ventricular insufficiency by contrast reflux studies, which can be mentioned. What other things can be seen are pleural effusions and pericardial effusions. Whenever a patient comes with right ventricular failure, what we usually grossly see is the dilation of the IVC. That is because of congestion in the systems. And that congestion is usually seen when an IVC diameter is more than 2 centimeters. So VEXIS score is something which has been right now being practiced more and more, especially in the bedside, and helps us understand systemic congestion better. So always failure was attributed to giving inotropes, and de-resuscitation and fluid management was not optimally done. So VEXIS usually helps us understand systemic congestion, which is usually seen in cases with RV failure. So it usually starts with the IVC diameter, goes with hepatic vein Doppler forms, portal vein Doppler forms, renal vein Doppler forms. What we need to see is the continuity, pulsatility of the waves and the morphology of the S and the D waves. So when we talk about hepatic veins, we see the systolic and the diastolic waves in the hepatic vein. And the pulsatility index is what is seen in the portal vein, and renal vein we see about the continuous monophasic flow as compared to a intermittent diastolic flow, which is seen in severe congestion. I'm not going into detail of VEXIS because VEXIS in itself needs to be discussed separately. Approach to the management of RV failure usually involves identifying the cause, determining the acuity, whether it is acute or chronic, and the origin of the cause, that is whether it is cardiac, pulmonary, or it can be because of drugs. So whenever we approach RV failure, we need to remove all the precipitant factors. Precipitant factors can be acidosis, can be hypoxia, hypercarbia, drugs, sedatives, toxins. All of this has to be thought about when we are thinking about RV failure. So what do we do? There's a line, I don't know. Guys, don't use markers well. Okay. Going about the management, the line of RV failure management usually involves optimization of fluids, protection of the right heart coronary perfusion. I have told you earlier as well, as compared to the left ventricle, right ventricle has lesser blood supply. So we need to maintain the map, consider reducing the RV afterload, optimize inotropes, and consider rhythm stabilization. Other precipitant factors like hypoxia, hypercarbia, acidosis should be corrected. Intubation and mechanical ventilation is something that is, very detrimental in these patients with RV failure because they have a very less physiological reserve and they can tip the balance into a precipitous spiral leading to hemodynamic decompensation when we put them on positive pressure ventilation. So these are the headings under which I would like to discuss RV failure management. So coming to volume management, IV fluids, usually what we think is RV failure is preload dependent. So vigorous fluid administration usually helps in improving the LV preload. And LV preload, if it's optimized, the cardiac output is good. But what we fail to understand is there is always the interventricular septum present. And if the RV is unable to pump against the pulmonary vascular resistance, it causes a shift of the septum, and this can cause hypotension. Okay, this is something that we need to understand. And it does not always mean that a patient comes with pulmonary thromboembolism. It's because it's a right-sided pathology. Load them with fluid. As of now, only judicial fluid resuscitation is what is advised in pulmonary thromboembolism. So is the fluid administration safe in right ventricular myocardial infarction? Is it similar to P? So what we discussed prior is probably it can worsen, right? Fluid administration. But is this the same thing when we think about an RV infarction? No. Okay. What usually happens is the primary problem here is decreased RV contractility, but not the RV afterload. So when the RV afterload is normal, what usually happens is RV becomes just a conduit. It's a passive conduit. It just takes in whatever fluid is given, and then based on the contractility or say about the heart rate, it helps to push the head of fluid which is present, fluid or blood which is present in the RV into the pulmonary circulation, thereby into the left-sided circulation. So IV fluid is often safe if it is required in RV, right ventricular myocardial infarction. So when do we use diuretics? So whenever we see a left-sided pulmonary hypertension causing right-sided failures, probably volume overload is the issue. And if there is signs of volume overload which is present, the patient can require diuretics. Usually, pulmonary hypertension also, one of the treatment of choices is diuretics. If the patient fails with diuresis, the next modality of treatment would be using renal replacement therapy, where the mode of RRT is ultrafiltration. Coming to protection of the right ventricular perfusion, what needs to be done is optimizing the MAP, use inotropes, inhale pulmonary vasodilators to reduce the pulmonary vascular resistance, and other arrhythmias which are usually associated with worsening RV failure needs to be corrected. So what do we mean by maintaining MAP? The same target of 60 to 65 is usually taken as a safe range. So the choice of inotrope here would not matter much. Again, we have to go with the choice of drug would be noradrenaline, and compared to that, next line of treatment would be vasopressin or dobutamine, depending on what reduces the pulmonary vascular resistance. So what has usually been seen is when we are using a lot of adrenaline, there is some amount of systemic vascular resistance which is seen that can offset the hemodynamic profile. Phenylephrine is something that we need to avoid because it has potential pulmonary vasoconstriction, and dopamine is usually avoided because it has pro-arrhythmogenic properties. So coming to inhaled pulmonary vasodilators, the major issue is the conduit and the delivery of these medications. The suggested doses are epoprostenol, nitric oxide, milrinone, and nitroglycerin. These are the things which are available, but to do it on a day-to-day basis, it's really difficult. The use of such medications are usually seen in patients on an operative settings, wherein the delivery of this is better when the patient is already on a mechanical ventilation, probably in a lung transplant or both cardiac and lung transplant cases, where we feel that the RV failure is setting in, probably these drugs can be used. So coming to rhythm stabilization, patients with RV failure are susceptible to alteration in the rhythm because the loss in ventricular synchrony causes drop in blood pressure. So both bradycardia and tachycardias are not taken good. Whenever there is a PAH, the most common arrhythmia which is seen is the AF that needs to be treated promptly. Digoxin is a usual alternative when you think about it after beta blockers. The other supportive care that needs to be taken care is the correction of hypoxia, hypercarbia, and acidosis, because hypoxia causes pulmonary vasoconstriction, the hypoxia pulmonary vasoconstriction that we all know about. And this in the long term can cause acidosis. That is again detrimental. So administration of pulmonary vasodilators has shown to improve, better VQ matching, and that reduces hypoxia and improves the HPV, that is hypoxia pulmonary vasoconstriction. Most important thing that I've already mentioned earlier is we need to avoid intubation as much as possible because these patients are prone to have cardiovascular collapse during intubation. So always keep a crash cart ready when you're intubating these patients. These patients are very, very labile. So any sedative that you take, please, a sedative, analgesic, or a relaxant, be aware of the detrimental consequences, which is the loss of sympathetic drive, which can drop the blood pressure and lead to a cardiac arrest state. So what are the ventilator settings? There's nothing specific that have been told, but what we need to remember is in positive pressure mechanical ventilation, there is decreased preload in the RV and increase in afterload, which usually causes drop in the LV volumes, which again further drops the cardiac output. So this is something that we need to know. So driving pressure is something that we need to keep a watch on. So better to do lung protective ventilation. The thing which have been the guidelines are not there, but what they usually suggest is a tidal volume of 4 to 6 ml per kg per body weight, predicted body weight, which is the ARDS protocol, with plateau pressures less than 30 millimeters of mercury. But this is not the a one size fits all again. We need to see how the patient's condition is. Probably we need to target a lower plats, lower driving pressure to avoid any hemodynamic compromise. Prone ventilation has been shown because the recruitment and better vest zones in proning can offset the hypoxia and hypercarbia, leading to better ventilation perfusion and causing better RV functions. So this is something that has also been noticed. VA ECMO, there is no evidence that if the patient has ended up in a refractory state of right ventricular failure, initiation of VA ECMO has given better outcomes, as it is something that of a mechanical circulatory device itself. The only thing is it might act like a bridge till we have a ventricular assist device implantation. The only thing which can save the patient at this particular time would be a transplant. So coming to the summary, always know the diagnosis, whether it is RV failure or LV failure. If it is an RV failure, assess whether it is acute or chronic. Look at the causes. What are the causes? If it's acute or chronic, whether it's an acute event like a pulmonary thromboembolism or a myocardial infarction, chronic being decompensated heart failures. Then treat the cause accordingly, because if we don't identify and treat the cause, optimizing next parameters would be unfruitful. So volume status, perfusion pressure, and myocardial contractility is something that we need to choose. When you're talking about optimization of hemodynamics, inotropes, which usually are taken into consideration, again, noradrenaline is the drug of choice. Myocardial contractility, you can try levosimendan, dobutamine, and milrinone. Again, we need to optimize a few of the status like fluid status optimization, and heart rate should be normalized, because again, offsetting these parameters can cause precipitous drop in cardiac output. If the patient is not improving with all of this, you can still try inhaled prostacyclins and nitric oxide and initiate the patient on mechanical circulatory devices. If the patient is not responding to all of this, the only final treatment in a right ventricular failure is both, probably if it's pulmonary hypertension, lung and heart transplant. If it's just the RV MI causing right ventricular failure, then probably heart transplant. Thank you. Any questions? I'll be happy to take any questions if there are on the chat box, or else you can just check text us on the group. I just got in touch with Dr. Sanantha sir. He is going to give you the class as a recorded session today. So once it is given and uploaded in this thing profile, they'll update you on the group, so you can listen to that class. The class is actually on types of MI and management of acute coronary syndrome, which is more or less practical question, but questions like types of MI can come in your theory paper as well. So this is mostly about cardiac system. Majorly, they have not asked many questions in cardiology. The thing is, this can come as a station, this can come as a smaller questions, but per se long questions have not come. Pulmonary thromboembolism can be seen as both cardiac as well as pulmonary, or associated with respiratory system. So if that comes, then we need to manage. So any questions we'll be happy to answer. And in the meanwhile, if whoever are present here, the 17 or 16 odd guys, do you have any other issues that you're facing? How have been the previous things? Have you listened to the recorded versions? We just need a honest feedback so that we can improve. Do you feel it is more monotonous? Do you feel that the content is too much? Guys, you can speak, right? Please speak up. It's for you guys. I mean, see, whatever you say, we have to take it into consideration because you guys are the ones who need to benefit from these talks. Please feel free to tell us. If not now, you can personally text us also. Okay? Thank you. Ma'am, do you have anything to say?
No, Darshan, that's it.
Oh, okay.
But guys, as Darshan told, if you have any issues, please let us know. Okay. Otherwise, we think everything is okay and we are just taking the classes. But if you have any issues, please let us know. Okay? Okay.
Thank you. Okay.
Thank you.
Have a nice Sunday.
Good night, everyone.
Navneet, are you here yet?
Yes, sir.
Hi, Navneet. I think so. We'll update them once the thing is present on the. I think when sir replies.
Actually, sir, Sanat sir already uploaded, but unfortunately my system got stuck. I'm unable to check, and as well as sir was telling like the voice is coming little slow, so
Okay.
I'm unable to check. I have already informed to Sanat sir.
Okay.
So,
Okay.
sir, if you could check, it is uploaded in uh,
The
faculty folder.
I'll just. I'll just
Yes,
look into it. And we will just have a look, and anyways, they can listen to
yeah,
it.
yes, sir, please.
Okay. Thank you. Thank you.
Yeah, welcome, sir.